Tylko ja muszę YouTube'a, nie? Włączyć.
Теперь они просто там фидбэков много заводятся часто, они не для подзвучных включения, они для там записи.
Один добрый один, один добрый.
Słaby internet jest. Może Pan wgrać na ten komputer? Prezentację na pulpicie wódek? Chcesz wszystkie mieć, czy gdzie?
Raz. Słychać mnie chyba tylko na laptopie, tak? Włodek. Włodek. No to jeszcze trzeba, żeby było mnie słychać. O, dobra. Sprzęga się. Okej. I jeszcze. Dobra, super. Jeszcze w drugą stronę. Output from the mixer to the input of the touch screen. Yeah. Okay, from HDMI. Okay.
Один, два. И раз.
Przedostatni kurs.
Ten, tak?
Tak. I jakby co ustawmy do tej modyfikacji, to tam się wyświetli oto. To z trójką na końcu.
Czyli to ma być, tak?
Tak.
Skopiuję. Pana prezentacja będzie która?
Słucham?
Pana prezentacja będzie która? Z kolei?
Druga. Jeszcze sprawdzę.
Dobrze. Dobrze, druga, tak? To wyświetlimy ją, tak? Żeby sprawdzić, czy jest wszystko w porządku. Okej.
Tam jest kilka filmów. Może Pan zacząć na pełnoekranowym, czy to idzie? Będziemy sprawdzić już na tym docelowym, gdzie będę
Dobrze.
działała system, bo to będziemy jakoś specjalnie coś naciskać, żeby filmać.
Dobrze. Włodek, możesz pendrive'a na chwilkę, bo byśmy chcieli prezentację sprawdzić.
Ja mam, ale tylko swojego.
To daj swojego. Że to już tutaj włączymy.
Ale ja nie mogę tego potem dać, to tylko dla sprawdzenia.
Dobrze, dla sprawdzenia, później przerzucimy na inne. Daję.
Można specjalnie.
Последний раз.
Что? А я что до этого? А вот 114, во, вот там же в двери 114, наши картонки там. А ключик можно взять это и використовувати.
И вот.
Pisak? Pisak. Czym? Po co ci ten fotel? Po co ci ten fotel? Co? Czemu nie ma sygnału? Czemu nie ma sygnału? Z kamery?
Что там в последнее время выделывается, да?
Co?
Что-то он чудит по носу.
Nie z Panasonica je.
Я?
Є.
А де ти бачиш? Більше немає? Сигнал? А, угу.
Tak.
I rysować. I rysować z dźwiękiem. Stream.
Что с ним договорить? Ну то что?
Proszę, давай зробимо.
Ну то что за звук?
Звідси.
А, она будет выключена.
Nie ma sygnału i tutaj nie ma sygnału i tutaj dźwięk trzeba wyłączyć.
Wyłączyć?
No wyłączyć, a po co nam dźwięk z tej kamery?
W pokoju video włączasz. Dobrze, nie wiem, pytałeś się Bartka, czy będzie dźwięk do Karla? Sprawdzaliście to? No to sprawdźcie. Jak chcę streaming włączyć?
Dźwięk powinien być.
Он еще не видит.
A?
Tak?
Tak?
Już tylko chcę zobaczyć streaming, czy działa dźwięk. Chyba działa, nie? Zakładam. Tylko chcę zobaczyć streaming, czy działa dźwięk. Działa. Dobrze, to już. Najpierw musimy przerzucić. Proszę powiedzieć, które to jest.
Chyba cały katalog trzeba przerzucić, bo albo ten katalog, bo tam są filmy.
Dobrze. Tutaj tak po kolei tak zrobimy. I pan będzie ten folder otwierał, tak? Jak rozumiem?
Sprawdźmy go.
Okej, dobrze. Bo chcę go nazwać jako drugi, tak? Okej.
Na prezentację trzeba zobaczymy, czy działa wszystko.
Znaczy my sprawdzimy tam, dobrze?
Okej.
Będzie prościej. To ja może ten cały katalog nazwę jako
Marcin Szymański to było.
2. Szymański,
Że?
dobrze?
Drugi, tak? Czy?
Znaczy właśnie pytanie, którą prezentację pan ma?
Pierwszej sesji, ale kolejności nie pamiętam.
Mieliśmy tutaj podgląd. Trzeci tuż. Okej. Teraz odłączam. Dobrze. Proszę. Przerzucam teraz na drugi komputer i otworzymy tę prezentację. Kopiuję się, jeszcze sprawdzę szybszego pobrania. 3 giga. A co? To zrobimy inaczej. Tu się zaraz... Skasujemy. Co? A ja prezentację zgrywam. No. Ale jak to? Panasonic? Kopiuję się, to chwilkę potrwa. Tak.
Poczekaj, my czuję, to musimy... Nie, przepraszam, ale to nie jest dla tego ten komputer. Dlaczego to robisz? Tym się zajmujesz? Przepraszam, jest ten. My nie mamy populacji z tej kamery. Da się było rano.
To można by było spróbować podłączyć bezpośrednio do OBS.
Przepraszam, tutaj jest dla prezentacji jest zaznaczona osoba. Ela Niemczyk. To proszę do niej się zwrócić i ona powie. Ona za prezentację. Tak. Przepraszamy. Ja nie widzę ani tej kamery. Dobra, ja tej też nie widzę.
Nic nie rób, nic nie rób. Złowek. Od złej strony zaczynasz. Otwórz panel do konfiguracji.
Nie kasuj tego.
Otwórz przeglądarkę i zaloguj się na portal. Jaki ty jesteś narwany.
On jest, nie radzi sobie z nogami.
Dystres bliski, weźmy liski. Zaloguj się na portal. Oszalany pan.
No.
Długo pracował wczoraj. No i weź układ. HDMI1 out.
Ale poczekajcie, na YouTubie widać tak New Line'a i widać Panasonica. Co ty chcesz jeszcze, żeby Ciebie widać? Wodek? Tak. A czemu chcesz się pokazać?
Layout, tak? Kliknij sobie to. Zjedź niżej. No i to masz USB-A. A do czego jest wpięty Lumens?
Lumens jest wpięty do
którego USB? W pełni.
do USB-A.
Tak? To może jest
Przepraszam, to wezmę Pani Elenę. Potem się zajmuje prezentacją. Nie. Tak.
Ja za chwilkę Pani wrażę.
Tak, a poproszę wgrać prezentację
Ja
będą z
pomogę,
tego komputera.
tylko tu się wykończy.
Tak. Mówię Ci, Ty robisz wszystkich dla ludzi, a tutaj nie mamy układu, który ja sobie wymyśliłem. Dlatego proszę ten... nie.
Standardowo, czyli
Standardowo. Właśnie. To jak to połączenie?
Było słychać.
Jak na całość? Aha, jak druga strona tam się podłączy wideo, to jest widoczne? Halo, słychać mnie? Okej.
Jesteś połączony.
Halo? Bartek, powiedz coś proszę.
Mówię.
Ja nie słyszę niestety.
Okej.
Tak? Weź.
Telefon sobie dzisiaj nie budę.
Znowu jest to samo. Za wysoko jesteś?
Wygląda na to, że znowu mamy podobny problem, czyli dźwięk sperma, który jest wypuszczany przez kolejny, nie jest wypuszczany
No dobry.
Ale to chyba nie jest możliwe.
Szczerze mówiąc, podłączyć to.
chłop, no to
Bo
chętnie.
on ma bardzo dużo filmów i chciał pokazać jakieś filmy
Okej, czyli na przykład...
A on nie może się podłączyć się do Newline'a? On może do Newline'a się podłączyć. Czy nie?
A ile waży ta prezentacja?
Tak dźwięk nie działa.
Dźwięk jest.
Nie działa na pokoju
Ty
wideo.
tym się zajmujesz.
A czym mam się zajmować?
Dźwiękiem.
Słucham?
Właśnie
Ja nie jestem dźwiękiem. Nie jestem od dźwięku.
Ale dźwięk jest.
Ale na pokoju wideo nie ma, rozumiesz? Jak ktoś się podłączy, to nie słyszy nas. Co? Po co ci to? Powiedz. Co? Możesz powiedzieć? Żeby cię ile jest? Ile jest?
Ale on ma jakieś... On ma Maca, a to jakie tam jest wejście? No to kabel bezpośrednio może podłączyć pod...
Ja nie
pod ten. No jakie ma wejście?
Tak. Staj.
Możemy sprawdzić, czy...
Jeszcze 85%, no niestety. Trzeba tak. Nie rozumiem, po co tutaj ta kamera jest. Szczerze mówiąc, wiesz, może promocja sam, wiesz, samego siebie. Tak, wiesz, podejrzewam.
Stawiamy tak jak jest teraz.
Czekaj, jeszcze sprawdzę tak. Możesz coś powiedzieć? Możesz coś powiedzieć? Słychać, chodzi coś? Tak, nie?
No właśnie. Tak, ale został. Ania wybiegła. W zasadzie nie powiedziała i pobiegła. Tata znalazł Anię. Pożegnamy się z widzami. Co to za ręka wyszła? No właśnie. Wiesz co, żeby w oczy nie świecić. Tutaj...
Marcin, słuchajcie, musimy zaczynać. To jest
Goodbye. Bye-bye.
Puszczać teraz, a cześć, no już bajki puszczałem, to już tam.
Chodź na chwilę.
Tak.
Good morning, everybody, ladies and gentlemen. On behalf of our ESBS President, I would like to start the session today. I hope you had fruitful days yesterday and the day before with the dissection course and the lectures and the operations and we learned a lot already. It is a small group, but this is the intention because the ESBS wants to promote young surgeons, scholar surgeons from the neurosurgical and ENT field to get closer to this always surgery and problems which will occur. So it is a great pleasure for me to be back in Warsaw again. And I have the pleasure now to open the session on Saturday with the first presentation of Professor Kowal. The topic is tumors of the frontal cerebral angle. Please go ahead.
Thank you very much. Dear colleagues, in the frontocerebral angle tumors, magnetic resonance is absolutely dominant and based on the patient's symptomatology, he or she is directly addressed to imaging magnetic resonance. But I would like to emphasize that somebody must send the patient. And once the tumor is found, the center or somebody competent will do decision what to do, either microsurgery, observation, and radiological is not very important for the diagnosis, but it may be helpful for deciding if there is sense to operate hearing presentation surgery or so. It's very modern. Dear Professor Niemczyk, Kazik, I would like to thank you very much for inviting me here, and I fulfilled my homework and I prepared some presentation of tumor of the pontocerebral angle. I have chosen some case reports out of the series, more than 500 patients. First, this pointer. Please have a look here. This patient was underwent magnetic resonance because of vertigo, and the diagnosis was set up very rapidly, and the tumor which was not so lateral because the food was empty, hearing was normal, and the criteria for hearing preservation surgery very good, and so we decided hearing preservation surgery. Here is the tumor, but unfortunately this vessel had to be coagulated and hearing was lost. Very correct and quick diagnosis The question now is if it was sensible for the patient in the other case, there is probably no doubt of indication of surgery because the tumor was very, very big, and what was the problem was the diagnosis. The patient was suffering 7 years from backbone pain, a lot of rehabilitation, and underwent also backbone surgery with no effect. Nobody realized that it may be the problem of severe intracranial hypertension. When the patient had tinnitus, was sent on magnetic resonance and the tumor was found, operated by suboccipital approach, but they did only biopsy and histology. He went to us and we removed the tumor. So our series of pontocerebellar anchor tumor, 90% of vestibular schwannoma, only 32 meningiomas and other tumors are very rare. We observed 75 tumors, majority vestibular schwannoma, and majority of these tumors do not grow, and symptomatology is not important for surgery. A typical case of cochlear vestibular symptomatology, the patient had only vertigo. At that time, magnetic resonance showed very, very small tumor in the meatus. 2 years later, the meatus was completely filled with the tumor, hearing was deteriorated, and next year we found 5 millimeter growth of the tumor, and the patient decided for surgery. She didn't want to live with the idea of having tumor head. This is a very insidious cause of the tumor. The man 64 and very big tumor. He lost his hearing at the age of 30, and up to 64 had no problems. Last 4 months started his ataxia. We removed the tumor, and so our philosophy is, if the tumor is big, more than 2 centimeters, we use lateral approaches, either translabyrinthine or transcochlear. If the tumor is less than 1.5 centimeter and the hearing is normal, we use minimal retrosigmoid approach. Here is a typical small tumor, normal hearing, and also functional test shows us that the tumor originated from the superior vestibular nerve, so it was good condition for hearing preservation. Tumor is out. Endoscopy shows empty meatus, and hearing was conserved. But after 5 years, you can see deterioration of hearing up to 50 decibel, and it is in our series very frequent finding that gradually hearing is deteriorated. radiotherapy and the vestibular schwannoma. We can see here very small tumor, at that time normal hearing, irradiation after 1 year, tumor growing after 2 years, after 4 years, already deafness, and you can see electroneuronography that it showed impairment of the facial nerve function, although his face looked normal. Here is the state after removal of the tumors. The facial nerve is conserved, and but the function of the facial nerve was Hausbrach 5. During 1 year, it was very much improved Brachfeld 3, but during this year, the patient had to undergo keratoplasty. So it's here is the case of a very big tumor and normal hearing. The patient had only symptom adiadochokinesis, and 3 years after tumor removal. In this case, I would like to emphasize that unilateral hearing loss, deafness, is not any obstacle for working as an interpreter. She knows several languages, and she works in Poland as an interpreter. Anesthesia face was the only symptom in this young lady. Normal hearing, big tumor, and during translabyrinthine approach, endoscopy after tumor removal, so it was a complete removal of the tumor. We had several cases like that. This was the man with this tumor, but 3 years before the diagnosis, he was treated by spondylosurgery because of the backbone pain. After three years, this schwannoma was found, and they decided surgery, neurosurgery, suboccipital approach, but did only biopsy and histology. Then the patient was recommended for radiation therapy. Radiotherapist refused irradiation, and he was sent to us. We used translabyrinthine approach, remove all tumor, and you can see here suboccipital craniotomy and translabyrinthine craniotomy. This is the case. Absolutely, this woman came to us in the terminal stage of the disease. She never visited a doctor, but in her 62 years, suddenly fell down and hurt her head, and magnetic resonance showed this big tumor with the cyst or cystic degeneration. It was subtotal extirpation of the tumor, and also hearing on the other side was improved because intracranial hypertension disappeared. In this case, there was the only symptom of otalgia, unilateral 10 years. Nobody could explain the pain every year, otoscopy and so. And then last 2 months before first surgery, he was very tired and started to fall down. So it was for a suboccipital approach. It was performed on neurosurgical department. The tumor was left, the cystic component disappeared, but the patient came with house Brachman 6. We reoperated by translabyrinthine approach, removed the tumor and grafted using intermedial graft from the sural nerve. 3 months after extirpation, the extirpation is total. This is a very good case. You can see that only computer tomography, because the patient was after cardiac surgery, some implantation of cardiostimulator and mitral valve surgery, and he used anticoagulation treatment. He was not aware of having tumor, vestibular schwannoma, but he came because of unbearable trigeminal neuralgia, sudden unbearable trigeminal neuralgia. After 2 weeks of preparation, he was operated, and you can see bleeding into the tumor. So overdosed anticoagulation treatment was responsible for bleeding into the tumor. This is the case of big meningioma, and the tumor was present also in the tympanic cavity. And here is, this is also the terminal stage of the patient of the age of 30. And she came for consultation Friday afternoon, and on Saturday external ventricular drainage was performed because she was much worsened. Monday we operated her by far lateral approach and would achieve subtotal extirpation. Post-operative cause was very severe tracheotomy, back nutrition, and after 1 year she can eat. She's without tracheotomy, but still very ataxic. This is the tumor. The patient was 75. Again, very insidious cause. Practically all his life had no problem but deafness, but he was perfectly accustomed to it, and started to fall down, operated, and we removed the tumor. Indication of magnetic resonance. At the beginning, I emphasized that somebody must send the patient on magnetic resonance. So unilateral sensory neural hearing loss is probably very, we are familiar, all otorhinolaryngologists, that this is the indication. Also sudden hearing loss or any kind of balance disorder, although found in the patient's history. But what is more problematic, typical, is normal hearing and otalgia only, or normal hearing and adiadochokinesis only, hypesthesia on hemiphase only. Sudden neuralgia of the fifth nerve, and the patient under anticoagulation treatment, somebody must bear think about the possibility of bleeding. Insidious pulse hearing is still normal. A patient tolerates intracranial hypertension very well up to the terminal stage, as we saw on these cases, 2 cases. The question is, are we familiar with the syndrome of intracranial hypertension? Now I see a lot of colleagues, younger colleagues, neurologists, probably are not so familiar with clinics. They are very good in imaging, but as I mentioned, somebody must send the patient on imaging. Also, neurosurgeons who operated the patient on the backbone, and the lumbalgia was probably caused by intracranial hypertension, because it disappeared after removal of the tumor and not after backbone surgery. And then the patients are in Slovakia. We have 8 neurosurgical departments, and they do sporadic surgery and of these tumors. The patients are concentrated in our department, and the patients come to consult, and they are sometimes very badly informed. So one must be prudent when informing the patient. The patient must get correct information. In the center which operates such a patient, the center must be able to prove the quality of life of the patients operating, and not sporadic surgery, I think, has no place nowadays. Thank you very much.
Yes, thank you very much, Professor Kowal, for this very interesting presentation and impressive cases you have in your country. Are there questions from the audience to Professor Kowal? Yes, please go ahead.
Thank you very much for the presentation. Could you please tell us your approach to the coexistence of hydrocephalus with big schwannomas, if it's clinically compensated? Do you perform external drains or previous VP shunts, or you manage them only postoperatively if it develops? Thank you.
Not external drainage. I am not a neurosurgeon. I was trained for this surgery, but I have no right to do external drainage. So if I need it, I cooperate with our neurosurgeons.
So normally, I'm neurosurgeon. Normally, in such cases, if it is an emergency case, you can put an external drainage for a few days, and then you should put in a shunt, VP shunt, because mostly in these cases you have elevated, let's say, or a changed CSF fluid, and therefore the resorption of the CSF is not as good as it should be, and therefore it is recommendable to use a VP shunt. You can use it before surgery, yeah. Afterwards, the infection is also a problem, so be sure that you put in the shunt, and some days afterwards you can do the operation. Any more questions? Yeah.
Yes. Congratulations, Juraj. I see that you really are devoted for this type of surgery. You operate bigger tumor, as we see here. So that's my question: is that really this tumor are sent from the whole Slovakia now to your department?
Yeah.
So that's really prove that you are the center of reference now there. And what is interesting for me, that's this case of radiotherapy, because it is still no ending discussion between us and how to deal with the acoustic neuroma patient, and some propose at the beginning observation, and this is very, as you know, big group in the northern country. And the radiotherapy, how frequent is in Slovakia now the group of patients send it to radiotherapy itself when compared with the group of who are operated?
I am afraid I do not have this piece of information, how frequent it is. Personally, I do not recommend radiotherapy. I recommend now more and more weighted scan tumors. Showed that the hearing after my hearing preservation success is gradually deteriorating. So small tumors now I prefer not to operate. We are two. I who do this surgery, younger and me. Small tumor for me now is operated only from pedagogical point of view. Somebody must be trained to operate this big tumor. If you do not operate routinely and frequently, how can you operate this meningioma? It's not possible. So I do not do small tumors, only big tumors, but younger surgeons do these small tumors. Hearing preservation now I prefer wait and scan. Radiotherapy, I have 10-15 cases when the tumor was growing after radiotherapy. Patients irradiated by gamma knife in Prague. Prague is the center for Slovakia.
Okay, thank you.
So, yeah, that's good to hear. So many questions. Go ahead.
One question. You are saying that hearing is becoming worse if you wait and scan through the ears. What's then the rationale of wait and scan for small tumors if they can be extirpated through the middle fossa, or some approaches if hearing is going to be better?
Now I am convinced, according to my experience and my results, that now I prefer to observe this patient and not to do hearing preservation surgery. I have some cases that I, in a minimal retrosigmoid, I left some very small part of the tumor on the cochlear nerve because I wanted to preserve surgery, and the young person, and after 2 years I found the same small tumor. So I did translabyrinth and removed it. And the hearing was worsened. But I have at least 50 patients under observation. The tumor volume is stable and hearing is normal. Okay. No clinical change. So I think it is not sense to operate now, but it is after 25 years of surgery. For somebody who starts, probably, I was like that at the beginning. I was happy I found the tumor and I operated the patient. Now it is different.
Okay, one question.
Thank you for your excellent presentation. I would like to mention again the radiotherapy process of the vestibular schwannoma. Until now, we know that 160 patients radiated by radiosurgery in the world. Then we observed that more cases after radiotherapy regrowing or still continue to growing. what is your experience about the surgery after radio treatment? Is it easy or difficult?
I don't want to use easy or difficult. The tumor always was removable, and I was always able to anatomically conserve facial nerve. But the function of the facial nerve was not good. But it is not only, it is combination. I showed that electroneuronography after irradiation because it was not because of the tumor. We do examine electroneuronography before surgery in all patients. And it is unusual to have electroneuronography. It was probably because of irradiation, but also the trigeminal nerve got some irradiation. So there is the combination of two. So the corneal problem because of loss of the sensitivity of cornea, the bad function of the facial nerve. Although after 1 year he had Haus-Brackmann 3, but during the 1 year period, repeated inflammations, ocular inflammations, and ulcus of the cornea and keratoplasty.
So I would say, to my experience, in the NF2 patients who got sometimes radiated because they want to preserve hearing or keep the hearing, it's more difficult to do the surgery. I remember some cases where I even was not able to see the facial nerve. It was completely in the capsule or pseudocapsule of the tumor, and no chance to get it dissected. So I think it is more difficult, especially in the bigger tumors. The smaller maybe not, but in the bigger ones it's. So we have to stop discussion now, otherwise we run out of time. I would like to ask Professor Kunert to present his talk, Possibilities of Facial Nerve Reconstruction. So this is a very interesting topic.
Ladies and gentlemen, thank you for the opportunity here. I would like to talk about possibilities of facial nerve reconstruction after its damage in CP angle and in temporal bone. Here is the plan for this lecture. I would like to describe some clinical situation when the facial nerve is damaged in this region. About 3 techniques I use, and some words on the best donor nerve and on the best time for this procedure. So if the nerve is sacrificed, but when we have the well-defined stumps, and if the reconnection is possible and to end during the same procedure, is the best solution. But unfortunately, this is rarely possible. So we can do such connection during the same surgery using suturing or sutures or tissue glue without sutures. Sometimes the stumps are also well defined, but there is a gap in between, so we can fill this space with graft. But also this situation is quite rare. But we should consider because facial to facial neurography will work best. Unfortunately, when removing the larger tumors, we have a situation like this. When the stumps are very thin, it's sometimes quite rarely in big tumors, the facial nerve is very thin, and we can even recognize there is no possibility to and no reason to try connect such stumps. And sometimes the site of damage is next to the brainstem. We know that the more proximal damage, the less chance for reanimation nerve after neuropathy in this place. So in such instances, I prefer delayed surgery with crossover techniques. Sometimes it's quite difficult situation to decide what to do. Sometimes the facial nerve is divided into separate bundles on the surface of big tumors, and what to do if one of them is preserved and other one is not preserved. Sami described in a case report many years ago the technique he used sural nerve only to fill the gap between one of bundle. We met in some cases such a situation that we were able to connect sacrifice bundle in end-to-end technique using tissue glue. There are several algorithms what to do and when to do after sacrifice of facial nerve. These are our complex algorithm, which was published a couple of years ago, but it still works. The classical hypoglossal to facial neuropathy was done more than about 120 years ago, and probably is still in practice, but the major disadvantage is significant tonal atrophy and hemitongue atrophy and its deviation. So in 90s of 20th century, a couple of researchers appeared on how to spare at least part of hypoglossal nerve as a donor nerve. For instance, RI described a technique of splitting nerve on a long distance, but the disadvantage of this technique is neuronal loss, because it's not too easy divide this nerve on, for instance, 3 centimeters long. Mai described the technique of interpositional jump graft using, for instance, the sural nerve, which was connected to the hypoglossal nerve and the distal stump of facial nerve. The disadvantage of this technique are 2 points of connection. So regrowing axon should go through the 2 connection sites. And Darroze described a technique called side-to-end hypoglossal, hemihypoglossal neuropathy. And it assumes the skeletonizing and rerouting the nerve from the fallopian canal towards and routing it towards to the neck and connecting with the hypoglossal nerve just with partial incision of the facial nerve. I use the last one technique, but with some modification. If I will be able, I can describe some tips and tricks in this technique in the end of this lecture. These are results of this procedure in clinic of Department of Neurosurgery, which we published 2 years ago. Up to now, I operated about more than 80 patients with this technique, with only one patient without any improvement after surgery, and more than 90% of patients have no tongue atrophy or very minimal tongue atrophy without deviation. Also, we can, using this technique, we can achieve pretty good results after radiosurgery. Some cases, some patients have facial weakness just after radiosurgery or just after radiosurgery followed by surgery. So in 5 of 6 cases we achieved the grade 3 of House-Brackman scale, and sometimes but the worst cases are NF2 patients. We know that the potential for regeneration is weaker in these patients, but still majority of them benefited from this procedure. These are faces after this procedure. Here we can see the typical appearance of the face before. Can you? What we should bear in mind that there is no possibility to achieve grade 1 or grade 2 after crossover connections, because there is no chance for recovery of facial function connected with emotions. So this is the best results we can achieve. So this is symmetrical face at rest, some voluntary movements with artificial smile, and eye closure without significant tongue atrophy. The second technique is masseter to facial neuropathy. We can use this when the hypoglossal nerve is also weak. This is a nice publication from 2014, anatomical study how to find the masseter nerve. But from practical point of view, it's not so difficult, because it's about 1 centimeter below the edge of zygoma, 1 centimeter upper beyond the mandibular notch, and 1 centimeter anteriorly to the temporomandibular joint. This is the incision for this procedure, and here we can see the air, the main trunk of the facial nerve, the masseter nerve. So these nerves are very close to each other. This is a patient after removal of huge vestibular schwannoma which penetrated into jugular foramen. I was not able to preserve the facial nerve. Fortunately, lower cranial nerves worked good after surgery, except hypoglossal nerve. So I decided to use the masseter nerve. Here is the line of skull base. Here is the masseter muscle, and this is the region when I look for masseter nerve. what to do next. No, I want to go further with this movie. Oh. So I use the bipolar probe to find this nerve, watching for the best motor response from the masseter muscle. Here is the probe, and here is the electrodes in this nerve, in this muscle, in masseter muscle, and the masseter nerve is cut off as distally as possible. And here is the main trunk of the facial nerve with its main division. The facial nerve is turned up and anteriorly to the stump of the masseter nerve. And also should we remember that we have to join fibers to fibers, not epineurium to epineurium. So epineurium should be peeled off on a short distance. Then we connect the stumps with sutures or only with tissue glue. Usually I use a minimum number of sutures. I prefer use gluing, using Tahosil without a conflict of interest. Usually I simply wrap the site of nerve connection with Tahosil. Next slide, please. This is not easy to cope with this. Oh. And here is the result of this. What I have to do, because it's a video. Okay, let's go. Doesn't work. Can I proceed further? Ah. So this is the side of surgery. The patient can close his eyes. We can see the effect of surgery on the upper part of the face and also on the lower part. And sometimes we can use grafts. There are two possibilities, maybe more, but they are most popular. This is a great auricular nerve, which can be easily found in the midway between the mastoid tip and mandibular angle. It goes up and it lies just beyond the external jugular vein. This is an instance of result after such surgery. I connected facial to facial nerve with the use of great auricular nerve. And somewhere it's on best donor nerve. My observations are similar to colleagues from Brazil, Sokolowski, Campero, and also Roton published this work in 2016. They found the hemihypoglossal facial neuropathy brings the most satisfactory results. Masseter to facial nerve, lesser but still satisfactory outcomes, and interposed grafts in hemifacial to hemihypoglossal facial nerve technique should be likely avoided whenever possible. But those grafts refers to the technique connecting hypoglossal to facial nerve, not facial to facial. there is no simple comparison for facial to facial reanastomosis. And what about timing of surgery? Obviously, if the facial nerve was not anatomically preserved during initial surgery, the neurography should be performed as soon as possible. But what to do if the surgeon is completely sure that he preserved the nerve, but it doesn't want to work? Of course, we should wait for spontaneous regeneration. But what to do if it doesn't appear? Initially, we waited up to the fourth quarter of the year. But now I agree with these recent suggestions that we can do this as early as 6 months after surgery, is if there are no clinical or neurophysiological signs of facial nerve recovery. So there is a tendency to do this earlier. Is there any reason to do such surgery in the second or third or fourth year of, which means long-lasting facial nerve palsies? I'm completely convinced that the second year are still good for this procedure. We shouldn't give up with this procedure, because it almost always gives better results than plastic surgeries. What with longer pulses? I have some patients after such procedure in a second, third, and fourth year, and in only one case I had no effect of surgery. But you can see, I decided to do this hemihypoglossal to facial nerve anastomosis in a woman in her 8th decade of life, with long-lasting palsy, with this, I think, very pretty good result. This is probably all. If it's allowed, I can show some short videos. It lasts about 3 minutes, tips and tricks, and maybe not, or maybe I can show it during the...
I personally would be very much interested to see it.
Yes?
Yes, go ahead.
Okay, thank you.
3 minutes.
Can we back to those movies? This is a line of incision for hemihypoglossal to facial nerve neurography. It goes just posterior to the ear. It then goes to the neck, just in the middle between mandibular ridge and sternocleidomastoid muscle, then turns anteriorly on the level of mandibular angle. This is our polygon for surgery. So this is a cavity after mastoid removal with skeletonized facial nerve. Here is a digastric muscle. It's very important because the easiest way to find the hypoglossal nerve is to find first the intermediate tendon of digastric muscle. The nerve is just beneath this tendon. There is no need to perform posterior petrosectomy to find and skeletonize the facial nerve. It could be done with minimal mastoidectomy. Here is a movie. How to do this? I prefer the technique from distal to proximal. So first I define the site of the extracranial portion of the facial nerve. I go up to the stylomastoid foramen. Then I identify the distal portion of the fallopian canal, and I follow up to the middle ear and labyrinth. The groove is, the width of this groove is about 6 to 7 millimeter only. The drill I use is usually first is diamond drill 6 millimeters, and for the rest I use 2 millimeter diamond drill to skeletonize finally the nerve in the fallopian canal. And now it's removed from the bone and turned down to the neck. Okay. Next thing, I do very short division of the facial nerve. What are purposes for this maneuver? First, this is additional length for tensionless. As we know, the connection should be tensionless and bendingless. And I achieve with this maneuver a very good fitting of the stance. So after such division, the half of the nerve is cut off. How to divide this nerve? The first we have to, using the sharp blade to cut the epineurum. Then we cut the surface of the nerve, and I divide the nerve using 2 microforceps. Which part of the nerve is better for anastomosis, anterior or posterior? We did the same what did RI a couple years ago. So after division of the nerve, but before cutting it, we perform electrostimulation, and we choose for connection the weaker part. Always it was posterior part. The aim of such maneuver is to spar the stronger part for the tongue. So now we use always the posterior part of the facial nerve. The neuropathy can be completely sutureless. I use the technique, as I mentioned before, using only Tahosil. So it can be only the site of connection can be wrapped only with this glue. Because Tahosil is simply glue. It's not a device for replacing Dura, but it's also hemostatic agent and glue. Connection is made. And the last trick is how to do the plasty after mastoidectomy. Is it needed to take fat from the belly? I use the pedicle, posterior belly of digastric muscle, and I turn it up into this groove after skeletonizing of the facial nerve. I had once a major complication of this before, namely it was inflammation of Petrous bone, and Professor Niemczyk had to rescue my patient with total petrosectomy. But after I introduced this procedure, I had no major complication with healing. Thank you very much.
Yes, thank you very much for these tricks and tips and this very nice presentation. So we have to move on. 2 questions, very urgent questions.
So that's, you mentioned, congratulations, Przemysław. So that's big experience you got now in this field, and but the main questions are still open, I can say. So that's the timing related to choose the decision about the reconstruction, because in general that's true, and this your 3 points is of course really good. It means that the best reconstruction is better. Well, of course, there are some cases with very last reconstruction, but however, in every case we reconstruct early is good. So that's the problem. What is your choice during the operation? So, for example, when you operate big acoustic neuroma and there is not a response, for example, and you see that the fibers are not, some fibers are destroyed, you have not the possibility to reconstruct the nerve in the end. So you prefer to make a type of reconstruction immediately, or you wait in this situation for AMG for 6 months and then you do that?
There are several completely separate situations, because if we are aware that the nerve is completely lost, there is no possibility to connect the stumps, we prefer do the second separate surgery in 1 month. So we discharge the patient home for a period of recovery, and we admit those patients again after 1 month and do surgery. When the nerve is anatomically preserved but doesn't want to work, we wait half a year and we perform EMG. If no features of reanimation appears, we do hemihypoglossal to facial nerve surgery in the beginning of the second half of the year after initial surgery. There is a major problem with patients from other centers, which I mainly operate. Is not our services because of we so often sacrifice the nerve, but many of Polish patients are referred to our department, and there is a problem with so-called functional vestibular schwannoma surgery, which in Poland often means that the tumor is not removed, but the facial nerve is sacrificed. So, so we perform the total, try to cure totally the patient with TLA, limited TLA, because usually these are not big remnants, and we remove the tumor remnant, and in the same time we perform a hemihypoglossal to facial nerve anastomosis.
Yes, one additional question, and the last one.
Thank you for the lecture. I'd like to know how many years after the palsy you may perform an anastomosis with good success, and if there is a parameter to know a good outcome.
The longest time was 4 years after palsy. In this case, I achieved a good result. It was between the grade 3 and 4. In younger patients, I tend to not to give up this surgery, as I mentioned, in the 3rd, even 4th year of pulse lasting.
So thank you very much for this nice presentation. And I call the next lecturer, Professor Szymanski, about the classic fish infratemporal approaches to lateral sculptures. Ladies and gentlemen, thank you for inviting me here, Professor Niemczyk, and having the possibility to present an overview of classic approaches described by Professor Fisch. Unfortunately, this comes together with the sad news I've received 2 days ago. Professor Fisch has died, and this will be a kind of contribute to his achievements. So, first of all, these were developed late, many years ago, but still most of the approaches are widely used, and you see with many modifications are still valid. So, we will talk about part of his developments, about approaches to the infratemporal fossa. And all of them, A, B, C approaches, they are based on subtotal petrosectomy, which was popularized by Professor Fisch. And all those approaches are described in details in this book. So, subtotal petrosectomy, as you know, this is a surgery where we eradicate so-called danger space for the brain. So dangerous because the middle ear can be inflamed. So we eradicate all the pneumatic spaces. We close the Eustachian tube. We obliterate the cavity with fat or muscle. So this way we have a safe area if the pathology was going from the temporal bone. So for all those approaches, control of the internal carotid artery was an issue for Professor Fisch. So it is always identified and followed to be sure that we are not injuring the artery. And for type E, another point is transposition of the facial nerve. So he will talk shortly about subtotal petrosectomy, type A, B, C, and if we have time, about extended petrosectomy. So subtotal petrosectomy means clearing of all pneumatic spaces. We have lateral, superior and posterior semicircular canals, facial nerve, cochlear, carotid artery, ostium of the Eustachian tube, jugular bulb, sigmoid sinus somewhere here, and skeletonized dura of the middle and posterior fossa. So after cleaning of all those pneumatic spaces, we obliterate everything, we close the Eustachian tube, and this way we have safe area. And in case of CSF, this patient is safe. So I will show short steps of the closure of the ear canal described by Professor Fisch. He develops like a periosteal flap, and we elevate and cut the ear canal like this. Okay, so we elevate the skin from the cartilage and put stay sutures, lead the skin outside and put 2 or 3 stitches to close the first layer, and then second layer, sorry. Okay, so the second layer was the periosteal flap. Go back, yes, that's it. So this is the second layer, and we put 2 or 3 stitches to have the double layer closure of the ear canal. This way, this is tightly closed, and no CSF should go outside this. Okay, so we close the ostium of the Eustachian tube. There are different techniques.
either with bone wax, or we mobilize the tensor tympani muscle and rotate it down into the Eustachian tube, or we use, some people use bone or short pieces of the incus to feed into the ostium of the Eustachian tube. The idea is to have tight closure and separate nasopharynx from the cavity that we create. The type A is mainly developed for treatment of paraangiomas, type C and B, so-called tubular valve paraangiomas, but also for petrous bone cholesteatomas involving carotid artery or petrous apex, or other tumors involving jugular foramen. So, for classification of the paraangiomas that was developed by Professor Fish, the type A is not developed for A or B type, but for type C, we have different stages of the disease. C1, C means carotid. C1, 2, 3, 4, and 4 is when the tumor is around the cell. And there is also some type D classification. D means dura, and D means extradural tumor, or D intradural tumor. So this, for example, would be C4, reaching around 7, E1, extradural tumor less than 7. So we use regular embolization of the tumor before surgery, and the main stages of type A approach is S-like incision, double-like approach of the peritoneal, like for septicectomy, and we identify lower cranial nerve, facial nerve, the main basal vessels in the neck, to do septicectomy. Then we transpose the nerve, we identify the carotid artery in the close the internal jugular vein and sigmoid sinus, and that enables us a safe removal of the tumor with jugular valve, close the Eustachian tube, and obliterate cavity. Morbidity, we always leave the patient with conductive hearing loss, because we obliterate the cavity. There is a risk of lower coronary nerve palsy, especially we are afraid of tenth nerve palsy. Facial nerve, because we transpose it from the bone, there is also always a risk of facial nerve palsy, and CSF, especially if we have intracranial extension of the tumor. So, incision, we start with A, B type, and C, and this part is done later on, just rotate the temporal muscle. So an important instrument for this type of approach is fish intertemporal retractor. This is quite a strong instrument, and this can do also some harm to the patient, because by rotating the screw, we have a lot of force to spread the tissue, and if you are too rough, you can stretch facial nerve or other nerves, lower cranial nerves. So there is also a special way to use it, not to compress the nerve, not to stretch the nerve, but this helps to gain some additional space for removal of the tumors. Like this one, this because it was meningioma, but this was operated recently, and the type A approach turned out to be chondrosarcoma. And also, this type of tumors, paraangioma, C4 paraangioma, with intracranial extensions, one. This is also a picture of the patient. And I present short stages of the surgery with C1 patient. So this is almost satellite petrosectomy almost done. This is right here. This is middle fossa. Tumor, despite embolization, this is not always working as we would like to, but we remove the tumor piece by piece to get to the facial nerve and to parodic. So then we will transpose facial nerve, relieve some soft tissue over stylomastoid frame to have something to grab with the second. And then we put it into the parotid gland. So we have some part of the tumor removed, but the main part of the tumor lies medial to the facial nerve. So we gently cut our connections with the developing canal, vessels with the developing canal, and mobilize the nerve. And then create a pocket in the parotid gland and rotate the muscle so we gain this much space for the tumor removal. The next stage is sigmoid sinus closure. There are various ways to do this. This is one of the ways that we have introduced recently. Previously, it was cut to the sigmoid sinus and put stitches inside. The other technique is to put stitches over it. And this is just trying to leave some bone here over sigmoid sinus to compress the sinus. So this is not open yet. And we just compress the sinus, putting some piece of material between the bone and sigmoid sinus. And this is blocked from superior ligament. If you remove too much bone here, then this is no longer a good technique, and then it's blocked by the open. And then now we go further down, and we open the sigmoid sinus and plug it with some surgical inferiorly. Of course, this is done after ligating the jugular vein, but still we have other sources of blood from the jugular vein, from inferior, or connections with inferior petroleal vein. So there's still some blood supply to the jugular vein. So we pack it, and then we can go further with two more removals. The next stage would be identification of the parotid. You have seen it yesterday during light surgery. So there's artery surrounded by the tumor, but also changed bone. The tumor infiltrates the bones soft. So we should make sure delicate to see the artery exposed. Identified all the nerves, so we can also remove the rest of the jugular vein up to the jugular bulb, leaving medial wall of the jugular bulb. So this is the inpatient of the type A. This is other patients with unusual bone tumor, osteoblastoma of the temporal bone, where we use the same approach, identification of the vessels on the neck. And on the facial nerve transposition, for many people, they say that this is always measured with facial nerve pulse. This is day after surgery, transposition of the facial nerve. This is a couple of weeks after surgery, and when we have paid attention and we are quite delicate, this is not an exceptional patient, and we can, in some of the proportion, there is slight weakness of the facial nerve, but after a couple of weeks, they should go back to normal. Okay, this is this patient after surgery, cavity obliterated. So we usually start with CT and then follow them with MRI each year. Type B, this this is more anterior focused approach for lesions of the petrous apex. And the main features of this approach is control of the horizontal shape of the carotid artery and removal of the temporomandibular joint. So we remove the base of the skull superior to the mandibular canal, to the mandula, to create a new temporomandibular joint, reach to the petrous apex this way. So in this approach, we identify the frontal planetary facial nerve. We divide zygomatic arch reflected inferiorly. It is a total trajectory, but we do not have to transpose the facial nerve because we work inferior to the facial nerve. It displays mandibula inferiorly, and then at the end we reconstruct the joint with the muscle. So this is one of the examples. This was giant cell tumor. This is the margins of the tumor. So we decided for type B approach. This start with the C incision, subtotal petrosectomy. We identified the frontal range of the facial nerve. This is zygomatic arch, which will be divided. It is divided now and rotated down to the temporalis muscle. And we start subtotal petrosectomy and removal of the tumor medial. This is still around the mandibule, but this is medial, this is mandibule. We follow the skull base until we reach the foramen spinosum and foramen ovale. And this is the limit of the type B approach. So we can remove tumor medial to the temporomandibular joint. At the end, we reconstruct the defect with rotated temporalis muscle. So during healing, the patient has a new pseudo joint and no problems with opening the bone between two. This is another indication of huge petrous bone cholesterol, and this is after surgery with type B approach. Complications with that approach is again conductive healing mass, not complications but validity. Bronchial bronchs, when we overstretch the tooth, is a danger as well. There is temporary limitation of opening the mouth in the early postoperative period. But even if we cut through the mandibular nerve, we have temporal anesthesia of the face. And now usually after 1 year, it comes back. And shortly after type C, this is probably the least used approach nowadays because this is for far anterior part, which is now reached by the anterior skull-base surgeons through the nose. But still, there are complications for type C, chondrosarcomas, nasopharyngeal carcinomas, recurrences after radiotherapy, or just 3 and 4 angiofibromas, which probably now are more through the nose. So the incision is far more anterior. We remove more of the zygomatic arch until the ring. Again, remove the skull base, cut through the mandibular nerve, and you can reach the nasopharynx through this approach. We use this a couple of times for this is recurrence of the carotid carcinoma, which some extension of the tumor into foramen ovale, and the patient has suffered pain a lot, so we use this as a palliative treatment as well, but this is around the ovale, from the spinosum. So we have removed the pathology and I think relieved the patient from pain. This is another indication is recurrent angioma, nasopharynx seen from lateral, and talking about extended petrosectomy. This is the approach for lesions anterior of the temporal bone, and also in the retromandibular fossa, and we use this approach mainly for malignant tumors, when we need resection together with mandible and diaphragmatic arch. This abdominal tracheotomy, diaphragmatic arch, and mandible resected. This is another example of this approach. So summarizing, I think for people that start or nowadays, the regular use of subtotal tracheotomy is correct to go further. So I strongly advise to use this and be familiar with subtotal tracheotomy, and then going to other approaches is just a small step. And summarizing, although there is a growing experience with endoscopic approaches for some of those pathologies, those classic approaches of presentation still valid and needed regularly. Thank you very much.
Thank you very much for this overview of fish approaches, which are often still important, but as you say, there are some replacements now with these particular techniques. So, 2 questions or 3 questions? Just
That's I think what for me this of course I think that the idea of the fish itself really real good choice in many cases. Of course, before the era of endoscopic surgery, choose for every type of fossa, lateral, base. That's obvious. Now it's a little limited, but of course we should underline that the general idea is really good because we start from the subtotal mesothelioma, and this is the most important technique because with that we get access to all the ground around this place. And of course, the problem is that to do, for example, the access to the posterior fossa, we should, however, make some modification. And as you have shown, because of this, make this manner of pushing anteriorly the mandible. It seems to me that this manner still is not necessary. You do really, I can say, some small modification of the technique. Do you use routine manner of pushing anteriorly the mandible in case, for example, of type A and subtemporal?
I think the tendency of sometimes not necessarily role, sometimes also good because you can direct and helpful, but I don't also the majority I use one of these Yes, actually, we work together with local surgeons, and they like this approach because they don't have to teach in conservative so far. We do some sort of treatment and it's now outside, so there's a different angle and not always familiar with this approach, but I think they acknowledge also this not enough need to push several adapters.
Thank you very much. One last question. If not the case, then I start with the next presentation. So we need still 3 to 5 seconds. As you have seen very nicely, is that in skull-base surgery, very often we have to be very destructive, use destructive surgery to get out tumors, malignancies, etc. On the other hand, you have seen a very nice presentation with the reconstruction of the facial nerve. So also the reconstructive procedure you should, as young neurosurgeon, know, and it should be in your armamentarium to know when to do reconstructions and which possibilities are there to do reconstruction. So I will talk about hearing restoration. So I just learned that we need 5 minutes for the slides, but I can continue. So I will talk about auditory brain stem implants and hearing reconstruction. So what is an auditory brain stem implant? I think many of you know already what it is technically and what you can do with an auditory brain stem implant. But imagine the following. Imagine that this is a man-made machine which gives a direct auditory input and contact to the human brain without any sensory organ in between. So there is a direct transmission of electric signals to the human brain without any nerve in between, without auditory nerve or something other nerve in between. And this is unique at the moment in medicine. And the next thing is that with this technique, people get hearing, some very well, some not so well, it depends a little bit. And on the other hand, it is possible that children who are born with aplasia or hypoplasia of the cochlea or of the cochlear nerve, they are able to learn and to get the hearing back and to learn to speak. So only with an electronic device, a man-made electronic device, these children get back into the hearing and speaking and communicating world. And this is also a very unique thing, and I think we as skull-base surgeons should know about that. And I think you can see it here. And we can continue with the second slide already. So when this method was starting, let's say the second start of this method, the first one was already in 1979 by the house ear people, Hitzelberger and House, but at that time the technique was not so much evolved. But with the upcoming cochlear implant techniques, the auditory brain stem implants had also a revolution, but at that time the people, mostly of the high-ranked ENT people, they said, oh, AI shouldn't be better than single-channel cochlear, or speech understanding will never be possible, or the open set speech understanding will never be reached, and ABI only may support lip reading, and ABI will improve hearing of environmental sounds. So the expectations were quite low. However, this is one of our first patients. In 1998, I operated her in Oslo. And she became an excellent performer. She had open set speech understanding. She learned another language, and she uses telephone. So that's reality. Cable running down into the
to the brain, to the cochlear nucleus. And this is the electrode which is placed at the cochlear nucleus in the brainstem to transmit the information, the electronic information of auditory inputs. And that's how it looks like in an X-ray. This is an older version of the implant. You see here the housing, you see here the zero electrode, and you see here the electrode which is going to the brainstem. And if you come a little bit closer, you can see here the electrode at the brainstem. And that's how it is worn from a sketch here. You can see here the coil which is transmitting the information, the processor behind the ear, the implant under the skin, and the lead and the probe in the foramen of Luschke. Go ahead. So until now, I personally have done around 140 implantations, mostly in NF2 cases, some also in children. And I will show you a few of the examples and the possible results of this technique. Next, please. You see here Louis. Louis is a charge child. So Louis has a syndromic disorder, and he has no hearing. He came from New Zealand to us, and this is after the first fitting. He is at home looking at his tablet. It's very interesting looking to it, and maybe you can, excuse me. So maybe I can do it here. Yeah. Yeah. No, it's okay. So that's the way it will work. Very good. Mm-hmm. Okay. It's okay. So I have to go back. So you see Louis, and I hope our audio will work. They are making some sound behind him, and look what he is doing. He's turning around and hearing to the sound. So this is the very first experience of him to hear sounds. And we call it category of auditory performance 1, just hearing environmental sounds. This is another boy from India, and he can communicate and do conversation quite normal with his parents. Without lip reading. And this is Xenia. She's from Russia, from St. Petersburg. I have to I try to behind you can see somebody, and she will tell her some words, and she's going to repeat them. So she does not know the words, she's just repeating them, and that means it is an open set speech understanding without lip reading. I know that the video is now shutting down, but you can hear it. So how fast she can repeat, and very correctly. So this is about 1 year ago, and at the moment she is cup 6 to cup 7. And she has no auditory nerve. Okay, we can stop it now. Okay. This is a little boy from India too. This was around his second fitting, and I show you this. The audiologists are singing a little bit. And you see clearly that he hears and reacts to the sound, and he says, it's too loud, I think. So they have fun, of course. This is the same boy a few years later. He has grown, of course, and he is now able to sing himself too. So the interesting thing is that he's able to keep the rhythm and to keep the melody, also without auditory nerve. So these are some numbers, just to show you about ours. Here is something, 40 ABI implantations, and most of them are at the age of 3 to 3.5 years. These are the category of auditory performance. 0 is nothing, of course. And then 1, I already explained to you, is awareness of environmental sounds. 3 means identifies environmental sounds, so he or she knows what she is hearing from the environmental sounds. And then I made a gap between 3 and 4, because with CAP 4, there is the beginning of speech understanding and discrimination of speech. And 5 means understands phrases without lip reading. 7 is uses telephone. And this is overview of our patients. So 84% are equal or better CAP 4, and around 50% are equal or better CAP 5. So around 50% of the patients, of the kids, they achieve open set speech understanding. And that means not only that they can hear and they develop speech, it means also that they develop their brain much more, that they are reintegrated in the society and in the world. Okay, now let's have a look to the adult patients. This is Mehmet. He is from Turkey. And he was, of course, not prelingual deaf. He suffered a meningitis and he became deaf. He got ossification of the cochlea. And so it was no chance to put in a cochlear implant. And I operated him in Turkey a couple of years ago. And this is an interview with him. Why doesn't it work? Good. I don't understand Turkey, but you see how fluently he can communicate. But maybe you can say it is good or it's not good. Okay, I think we can stop it. And this is another patient. This is Karol. Karol is from Poland. And he's giving a talk at this, as you can see on this slide, 2009 at a cochlear implant conference. And these are the tumors Here's NF2, which were removed, and you see below the the implants. And this is speech comprehension of Carol with a monosyllabic word test in noise. Monosyllabic word test is one of the most difficult tests, not sentences, but only to get a monosyllabic word, and he has to recognize this correctly. And what you can see here, from the bars, is that he had the blue bar is the ABI on the right side, and the red one is a hearing aid. And after hearing aid was not longer suitable because of his hearing loss and the tumor growth, I implanted him with an ABI on the contralateral side. However, he had postoperatively a bleeding. It was the first and only bleeding after surgery I had. And this was the result of the ABI on the right, on the left side. You see, it is very, very low what you can hear. But when you combine both, he has the benefit of 10% of correct monosyllabic words in noise. And no, I have to close it now. I'm sorry about this inconvenience, but we manage it, no problem. So just have a look. That's him. He's a musician, and he's performing rap music, and this is one of his compositions. You can see both ABIs on the left and the right side. And you hear him singing. And you see he has no facial palsy. And he created the slogan, "Life after death." Okay, I think we can stop now. You have seen the most important things. Okay. Yes, that's the right one. So it was in 2008 and 2009 when most of the people doing ABI surgery, they didn't believe that these results are possible at all. That NF2 that NF2 patients are able to get an open set speech understanding. And therefore, from the House Ear Institute, Professor Bob Shannon, the audiologist, the chief audiologist there, he came over to Germany and to Warsaw, and he examined the patients, and he came to the conclusion that it is really true that NF2 patients are able to get results like the best cochlear implant patients, even after tumor resection. And this he stated in this slide here, that some NF2 ABIs are able to understand speech understanding or speech similar in the best CIs. 100% of open set speech understanding, controversial use of telephone, speech recognition in noise, and so on. So from that time on, it was clear that, to the community, it was clear that ABI is a really option for these NF2 patients and also of the other patients who have no cochlea and who have no auditory nerve at all. Asking the patients after ABI implantation themselves, how do they rate themselves? So that 33% are very satisfied and 40% are fairly satisfied. That means 73% are very happy and 25%, 1/4, is adequately satisfied. So, as I said already, not all patients are able to become such good performers. And we try to find out what is the reason for that, or are there any prerequisites to become it. And therefore we investigated the NF2 patients which were implanted with this device, and we identified that out of this series of patients who did better than 30% of correct sentence recognition, we found 31% who achieved this level. And factors we found to become a good performer are a short duration of deafness, a high number of different tones of different pitches, a low maximum comfortable level, high stimulation rate of the implant, the operation, of course, we like the semi-sitting position, and an intraoperative EAVR recording, and not the tumor size. The tumor size was not significantly correlated to the outcome. But of course, if you operate a smaller tumor, it's getting much easier for you and for the patient. So patients better than 30%, they had a minimum number of 5 electrodes and minimum number of 5 pitches. That means 5 different tones. A maximum stimulation rate of 350 pulses per second at electrode, and a maximum stimulating charge of 141 nanocoulomb. And patients who did better than 80% sentence recognition had 8 electrodes and 8 pitches, a minimum stim rate of 1200 pulses per second at electrode, and a maximum stimulating charge of very low 28 nanocoulomb. So that means in those patients where the electrode was placed very accurately at the cochlear nucleus, at the very sensitive spot of the cochlear nucleus, they did best. So it is a clear message that operation and placing of the electrode is of crucial importance. And what we recommend is that for selection of patient, the duration of deafness is important. The motivation, of course, of the patient and also of the caregivers who care for the patient. Of course, you need diagnostics. That's not an issue. The setup, intraoperatively, we like to use the semi-sitting retrosigmoid approach. We do very intensive monitoring, and we do the EBRAs during the operation always. Surgery, of course, it has to be very delicate and painstaking. And what is also of very important is that the fitting from the audiologist is done very, very intensively with a high motivation and lots of experience. So what are the achievements with the ABI? In general, we can say that the ABI system has proven its safety and efficacy. There is a CE mark. It is also certified since 2017, I must say. 18 is not quite correct, for the implantation in non-NF2 cases older than 1 year. And it is proven its compatibility with MRI of 1.5 Tesla. And clinically, it has proven effectiveness in NF2 patients, effectiveness in pre- and post-lingual deaf patients, possibility of bilateral implantation. I didn't mention that. Of course, it can be revision surgeries done, and we perform some training workshops and so on this issue. So I thank you for your attention, and excuse all these technical things and problems we had. But I think the message is done.
Thank you, Robert, for excellent lecture. And we excuse for this technical problem, but we would like to combine everything in it with transmission to the internet, so broadcasting. And as you see, it is a little still difficult to have good timing. But Robert, you showed very interesting problem in this type of hearing aids implant. I have two questions, in fact. One concerning this sleeper concept of this implant, ABI implant, because Carol is, in fact, get implant in this sleeper philosophy. So from one side he had worn hearing aid, and from other side he got the brace implant. For me, it is good option really, because he can have rehabilitation during this time. And the second question, which is of great importance, and I think this is very rare, this bilateral implantation, because it's rare. And what are the advantages for bilateral implantation of brainstem implant? What are the indications for that?
Yes, thank you very much for these questions. The first, the sleeper philosophy, let's say, in its original version, doesn't exist anymore. So at the first time of ABI surgery, we said, okay, if there is a tumor on the second side, and even if the patient is still hearing very good, we do an implantation because the patient may have the possibility to train and exercise and gets the true information from the good ear. But it proved that they don't use the ABI then, because the good ear is too good. In Carol, it was that he had already a relatively big tumor on the left side. The right-sided tumor was operated first because it was very big, and he got his implantation. But we thought that in a very short period he will be candidate for a second implantation or a second operation for the remaining tumor on the left side. And it turned out that we were not quite right, because he used a hearing aid. And of course, it is always the same in the NF2 patients. They want to have their hearing as long as possible. And even if the tumor is growing and they still have some hearing, even if it's not so good and if it has to be augmented with a conventional hearing aid, they want to keep this hearing and they don't want to be operated. But when he realized that with the hearing aid, I showed this figure, when he realized that with the hearing aid, the hearing on the left side was decreasing and getting worse and worse and worse, then he said, okay, now I want to have the operation. I want to have a second ABI on the left side, which is not normally paid by the insurance companies. This is one problem. You have always to have a fight, and in his case, I think he paid it from his own, if I remember it right. I don't know exactly. And then we had this complication with the bleeding on the left side, and I had to go in the day after surgery, remove the bleeding, and of course we had not really a good control of the implant. And it turned out really that he has not a good result on the left ear, but he has some result. And with both together, he increases his hearing. And I have some other slides where you can see that even a directional hearing is there. So this is possible, and what he says is that his hearing effort is much less when he uses his both implants. So now I come to your second question, bilateral implantation. I think it is an issue. We started the same thing with the cochlear implants. First of all, in the beginning it was only one cochlear implant, and then it started with 2 implants, especially Joachim Müller was there active on this field. And yes, indication. In principle, in every patient with a NF2 disease, it is in principle an indication for true ABRs, because you have 2 hearing pathways, and it may happen that one hearing aid is worse than the other, or during time it gets worse than the other, and then you can rely on the better side, and if you combine both of them, there is a better hearing for the patient, and the hearing is easier. So this is, I think it is indicated. The problem is that it is not taken by the insurance companies, and you have to fight with the insurance companies. At the moment, I have 4 or 5 patients who are implanted bilateral, but at the very first beginning, and I cannot really say the results on them with the 2 implants. But Carol, I told you. So I strongly believe that it is important to have 2 implants, but it will take, I think, at least 5 to 10 years to convince also the insurance companies that it is important to have not only 2 glasses, left and right, but also two hearing aids. Yeah. So. Yeah.
Curiosity for you, Robert. It was very nice that I have been sitting. Otherwise, I will fallen down because of the excellence. And I must stand with your data. Did you perhaps ask or communicate with the patients with post-lingual implantation? What are the difference between the sound sensation? Because it is the matter of electro-engineers and algorithms. What kind of
yes, the post-lingual patients, they I understand.
Good data for our further.
The post-lingual, we didn't examine it scientifically, but what the patients tell us is, first, they have less tinnitus when they use it, and second, the sound they perceive is a little bit more like a computer sound, a little bit more electronic sound. But the interesting thing is, when they get another cue, let's say when a husband or a wife speaks to her husband or vice versa, and she or he sees the other person, then that's the hearing is as it was before. But when not, then it's more electronic. So there is a mixture of all the input in our brain, which creates let's say a combined perception.
Hearing engrams.
Yeah, like an engram. Yeah, right.
What about the music? Is there any music hearing?
Yeah.
Are there any?
Yeah, this is possible to some extent, but it is not as well as with the cochlear implants. It is better with the cochlear implants, and of course it is much less than in natural hearing. But they can get some rhythms and some melodies, but not as good as it.
Still electro-engineers.
Yeah, it's still, yeah.
Thank you very much. Just curiosity.
That's another question.
Professor, thank you for your sharing your excellent results. A couple of years ago, I have heard about the concept of ABC implant, which is auditory brainstem and cochlear implant in the same time. What happened with this idea? And what is your opinion about this?
We have in our series one patient with a cochlear implant and with a ABI, and in combination, the patient is benefiting from it. It's in combination, it's better, but in total, let's say this patient is a female patient. She is not a good performer. So she has not open set speech understanding, and I don't know at the moment. I don't know I think yes. She had since years deafness on one ear, and she had got a cochlear implant on that ear, and the other was acoustic neuroma, and we put in a ABI on the acoustic neuroma side. This was an elderly patient, and she developed no open speech set understanding, but together she has an improvement. So it is possible, and it is only, let's say, a solution for selected patients where it makes sense to use both implants, and but it's not a contraindication to combine them, if this was your question.
And the second short question, because the results are improving over the years, and what do you think? What is the main reason? Better devices or better positioning of the RI in the foreventricle, or maybe post-surgery training? What is the most important?
That's a good question. I think it's all of them. I think one side of the medal is the surgery, but the other side is the post-op rehabilitation. And if you do this correctly and with great enthusiasm, you can improve the patient significantly. If you come with an attitude, ABI, let's see, and like this, then it's not good. You have to force the patient to improve himself and to motivate to use it and to get out the best fitting for him. And maybe you have to change this fitting sometimes over a certain period, many times, to make him or her better with the hearing. So this is one very important side. The implant itself technically is also improving a little bit, but I cannot say if it's really one main part of the story. But surgery, yes, surgery, you get more experience over time, and therefore, as I said, it's very important to place the electrode at the hot spot of the cochlear nucleus. You get some stimulation results even if you're a little bit away from the nucleus, and then you have to move the electrode only by parts of a millimeter, and you get better results. And therefore, we recommend this test electrode, which has only four electrodes, not 12, 4 electrodes, and you can move it quite easily in the lateral recess and try to find the best stimulating results during surgery, and then place the stimulating electrode with the 12 electrodes just at that position. So I think it's a combination of all of the arguments you mentioned.
Thank you very much.
Yeah.
Yes. Thank you, Professor, for your presentation. And I want to ask about what is the latest timing for implementation of implants after the first surgery? Because you show us, I mean, for acoustic neuroma, you show us a lot of patients from different countries, and probably they were rated in different institutions, different hospitals. What are the latest procedure after the first surgery?
In most cases, the tumor was resected and the implantation was done in the same procedure. It depends more on the time of deafness, because the tumor causes deafness, and not all patients are operated when they have some residual hearing, which is lost during surgery. Many of the patients are operated when they are already deaf for a certain period of time. And what we found is that it is important that this period of time is very short. So statistically it was 1 year. But of course the indication is then for 2 or 3 years. It's also still an indication. But maybe the results will not be as good as you plan to have them. So you should tell the patient that, of course, that's why I'm talking about it. Let him know that it is important to do the implantation very soon after deafness, after the patient became deaf by the tumor or by tumor. So if you go in as the second surgery, after you have removed the tumor and wait some time, and then it may be the case that there is some residual hearing during surgery, if you need your ABI cars, but the patient loses the hearing over time after surgery, and then of course there is an indication. And then it also depends how long is the time between loss of this residual hearing and the surgery. But to say after 5 years it makes no sense, I think this is not worthwhile to do.
One short question is, how can you choose the site implantation can be for both sides here with the patient if they were operated?
Yes. First of all, I would ask how long is he or she deaf on which side, and I would first choose the side which has the shortest deafness. And then, if it's all the same, let's say it's all the same, and the brainstem is looking good in MRI, there's no lesion on the brainstem, then it makes no difference. You can use the left or right side, and then I would ask the handed side, yes. If it's right-handed, I would use the right side, left-handed, left side, or try to bilateral.
Probably you are a bit tired, but firstly, I would like to thank the organizing committee and especially Kazimierz to invite me, and it was very honorable to part of first skull-based surgery section course and conference. Thank you all of them. And then my topic is unilateral subfrontal approach to cellular paracellular area. Especially, I would like to mention literature detail of neuroanatomical orientation at this special area and our own clinical experience. As an overview, it is very challenging pathology of cellular paracellular areas. Maybe it would be better to focus on craniopharyngioma for talking about subfrontal approach to cellular paracellular area. To the craniopharyngioma, ordinary approach to preferred paths are bifrontal, pterional, supraorbital, interhemispheric, and nowadays the most popular one is the transcranial, as you know. Yaşargil described 4 types of anatomic localization of craniopharyngiomas, respectively intracellular one, intrasupracellular, supracellular, and intraventricular. Also, Yaşargil has explained that approach used for localization of craniopharyngiomas. If you look at this approach types, pterional approach is the most popular one. And he didn't mention subfrontal approach as an approach for this area. If you look at the textbook of Coles and Spessler, they describe growing pattern of craniopharyngiomas and possibly base of the approach. There are 6 sample cases presented on this section on their textbook. Interestingly, all of them operated by subfrontal approach. I mean that 2 authors looks the same area, and one of the popularized the pterional approach, other one of the popularized the subfrontal approach. The most important anatomical area for this location, the optic chiasm position. It is the crucial for subfrontal procedure and also pterional procedures. With a mid-fixed or post-fixed chiasm, the tumor can really be removed between the optic nerves anterior to the chiasm. Whereas with a prefixed chiasm, theoretically it's possible to remove it, but many times it is impossible. If you look at the anatomic pictures of this area, we see the cellular paracellular region from the subfrontal corridor of these pictures. The appropriate approach to lesions depends on their specific anatomical location. and various ways of exposing lesions depend on their location and extension. Commonly, the complete resection of the lesions requires access through various anatomical structures. For access through the lamina terminalis, for the tumor portion extending into the third ventricle, we can prefer the unilateral subfrontal approach. And if the lesion is located in the intracellular region, we can obtain direct access through the between optic nerves by using unilateral subfrontal approach also. Another way, as you see that, between optic nerve and carotid artery, especially lateral extension lesions. And for lateral extension lesions, another one is between optic artery and oculomotor nerves. Pterygium approach, as you see that, gives us many opportunity, and as a neurosurgeon, we would like to use this approach routinely. And then the pterygium approach may provide adequate exposure to resection. The lateral extension lesion is located between optic nerve and carotid arteries, and between carotid and oculomotor nerve, and also below the oculomotor nerve located lesions. As shown in the stage of Danby, we can see the extensive subfrontal approach, and also as a reference from medical clinic, classic bifrontal approach to skull-based well-known process. Bifrontal craniotomy is necessary or not. It is not necessary to perform extensive bifrontal craniotomy to have this nice review of the exposure. We thought that. And because of technical advantage of microsurgical techniques, it could be possible to have this nicely view of the anatomy with unilateral subfrontal craniotomy. You were using bicoronal incision for unilateral craniotomy. Right now, we are using a supraorbital linear incision and just a Van Gogh hole, and craniotomy is performed with inferior burr holes placed as close to the floor of the frontal base as possible. It will be rectangular shape, and CSF drainage will be key point of the exposure. If we need to use blade for retraction of brain, the best way to use the blade of the lateral position. Another important point is to use the thin blade with pulsation-free brain retraction. Whereas the unilateral subfrontal approach is convenient to reach intracellular region and through the lamina terminalis to third ventricle. And subfrontal approach provide us the straight ahead view and direct surgical access to specifically through the between optic nerves and intracellular optic nerves to intracellular lesion. This is an example case from my data. Using subfrontal approach is convenient to reach intracellular region. 2 years old child who previously shunted in different centers. There was severe compression of brain stem by solid and cystic part of the tumor. Sagittal leads show cellular, supracellular, and intraventricular parts of the tumor also, and coronal view same shows. After opening the dura, as you see that, the cerebral use was used to obtain better retraction. We are directly going to the lateral side, like a Sylvian using the terminal approach. And then gravity of the brain gives us the opportunity to release the CSF. This is the carotid arteries, as you see that, and optic nerves. This is the carotid optic triangle. And we are going to midline, from lateral to midline. This is the optic nerves and chiasma. As you see that this is not graphic chiasma. And tumor is coming up to our view, and we are continuing to remove tumor piece to piece. And because of position of the chiasma, it is not possible to go to laminar terminals, and we are going to, for this special case, to interrogate abortion and the same time surgery. This is the post-op first day MRIs, sagittal view, and post-op T2 and post-contrast views, axial, and this is the coronal T2 and post-contrast MRIs, shows good hospitalization of the tumor. And first day after the surgery, the pictures, and we are still continuing to follow this child from Algeria by phone call. The subfrontal approach provides us to straight ahead view and direct surgical access specifically to the lamina terminalis to third ventricle extension lesions. Also, we see the relationship between lamina terminalis and third ventricle in the second picture on the right side. And this is an example case for lamina terminalis exposure. This lady is 30 years old. She has supracellular and intraventricular tumors. This is the coronal view of the MRIs. As you see that there is solid and cystic part of the tumor. And the same approach, you see that. And then we proceed in subfrontal corridor with gentle dissection. This is the opening of the carotid optic triangle. And after opening the system, release of the CSF gives us the opportunity to see area step to step. We are using magnet sector and sharp dissection. It is possible to see both sides of the optic nerves, chiasma, and also other triangle between carotid and optic nerves. This is the right side, and the left side we saw that. And right now we are going to third ventricle by using lamina terminalis and then we see the tumors, all part. Firstly, we see the cystic part of the tumor. Gently, we open more the lamina terminalis, and piece to piece, it could be possible to remove the tumor. As you see that. Continue to remove them. And post-op MRI scans axial T2 and post-contrast MRI shows vertical resection, sagittal one, and this is the axial one. These are the 3 years follow-up MRIs, and she is doing well right now. And this unilateral subfrontal approach also provides direct access to lesions which are located between optic nerve and carotid artery, beside pterygium approach. Same. The yellow arrow illustrates our trajectory to using at this approach, and we have to avoid olfactory nerve injury. And then finally, we can say that unilateral subfrontal approach can be suitable for this kind of cellular paracellular area pathologies, but this approach is not suitable in certain lesions which need to be exposed from a more temporal perspective. This is the point. Current literature gives us the opportunity to compare the result of this approach to other ones. And then if you look at the Danish national study, they find the outcome of subfrontal approach is better than others. Another study from China, in this study, authors analyzed the result of unilateral subfrontal approach for craniopharyngiomas. The result shows comparable better result of total resection rate, progression-free survival, and overall survival rates. And also, they present very nice rate of living independently with acceptable morbidities also. In this study, authors compared surgical and endocrinological result of surgeries and very comparable good results they presented in their studies. To focus on pathology-based analysis of subfrontal approach here, in the last 10 years, I had 43 cases with craniopharyngioma. You can see the distribution of the approach on the slides. The results of unilateral subfrontal approach slide has 20 cases. We performed 2 cases combined approach with transcallosal one. In totally 22 cases. Total resection was achieved in 20 cases. Tumor was detected in 2 cases. And lying independently with acceptable morbidities were in 18 cases and no mortality. This is an example of supracellular located craniopharyngiomas others. Preoperative MRI show solid tumor. This is the sagittal, pre-op, and postoperative MRIs. And as you see that on the axial view, clear imaging, that is the ischemic area. We have to be careful about damage of the anterior perforating substance perforating arteries. But this lady's recovery was uneventful and she's right now doing well. If you look at advantages and disadvantages of this approach, this is a simpler procedure, small craniotomy, minimally invasive retraction, convenient drainage of CSF is possible, and good view of bilateral supracellular structure, direct access to originating location of the tumor, and others. This is the main advantages. If you look at the disadvantages of this approach, risk of olfactory nerve injuries, insufficient use of lamina terminalis window depend on location of the chiasma, difficulties from low positioning of A1 segment arteries. If there is this kind of situation, we have to combine this approach other one, like inter-hemispheric approach to cellular paracellular areas. And then skull-base surgery requires a huge teamwork. We know that. I would like to thank our team. As a conclusion, I would like to mention that there is no one best way. There are more than one. We learn from patients. Skull-base surgeon has to perform tailored surgery for prevention of patient-life quality. We have to consider that all of this approach could be better. One will be we feel it must be our way, and we have to spend time in anatomy lab. Finally, I would like to invite you Boston International Neuroscience Expo 2020. Last year, Robert Spessler was our guest of honor, and the topic was neurovascular conference. It is a great pleasure for me to invite you posterior fossa conference in September 2020. Thank you for your attention.
Just a short questions. First, do you release falciform ligament during approach? I mean, dural ring covering superiorly the anterior surface of the optic needle.
We don't touch the classical ligaments. If we need it, we change our way to combine it.
Okay. The second, do you tailor the body opening according to the size of frontal sinus, and if not, what do you do when it's open?
Yeah, neuronavigation gives us the opportunity. We can change our direction to a little bit lateral, and like a combination of the cranial average and subfrontal average.
Okay, understand. But sometimes it occurs. What do you protect the opened frontal sinus? If it occurs?
Yeah, classically, as a neurosurgeon, we perform bone alone, and after that, we use the graft and close with some kind of match grafting, like titanium match for anatomical correction. Yeah.
Thank you for your presentation. What is your strategy with pituitary stroke, chronic rosmosis
strategy?
Do you sacrifice it, or you try to preserve it?
Pituitary stroke. Yeah.
Because
as mentioned, I mentioned that if we look at our 22 cases, there are 18 patients. They continue their life quality without any unacceptability. Because of them, healthy craniopharyngeal cases, healthy craniopharyngeal is a chronic disease, and many of them take endocrinological support. If we need it, we start the stuff, and then because the first surgery is the best surgery for craniopharyngeal. Our way is this. Second and third one will be done.
Are there any questions? Any more questions? One question. Just a moment. I remember in some cases where we do this approach, it's possible we put the communicating artery very immediately dissect. So we can either approach this line,
I mentioned the position of the anterior communicating artery. This is the disadvantage of this artery. It depends on anatomical speciality of the patient.
I think the need was helpful to dissect Okay, so thank you very much for your contribution. We have the last session in this first part by Dr. Group, imaging of the skull instrument.
Thank you for the invitation, Professor Kazimierz and for the introduction, Professor Berg. It's really a pleasure to be here. And I would like to talk about imaging for skull-based tumors. I'm a radiologist, and in the European Society of Radiology organized skull-based imaging process. It usually takes 5 days to get familiar with the technique. Today I was asked to do it in 20 minutes. I don't know how to do it. It sounds like a mission impossible, but it's going to be okay. professional 90 minutes. Okay. When it comes to skull-based imaging, CT and MR are complementary techniques. And on MDTs, ENT doctors, they always ask ENT doctors if they have a patient with skull-based tumor, if this patient has CT and MR, because usually both modalities are needed and provide additional information that helps to establish diagnosis and to choose proper treatment, to choose best surgical approach for biopsies. Okay? So CT and MR are complementary techniques. CT allows to depict body anatomy and to assess neuroforamina, to detect bone destruction, to detect calcifications, to detect sclerosis, fibrosis, the slice thickness of 0.3 to 0.6 millimeters in bone reconstruction powder is recommended. MR gives us information about the tissue characterization and it allows for better tissue characterization than CT because this modality has better tissue resolution. This modality allows us to depict intracranial invasion, peripheral spread, brain parenchymal invasion, meningeal invasion, invasion of the organ, invasion of the common sinus, or pulmonary involvement. MR imaging protocols when it comes to skull-based are different in different departments. In different departments, but T1 sequence, T2 sequence, and T1 post-mortem sequence, with or without fat saturation. Of course, we always observe those pathologies in multi-color, so cerebral axial planes, coronal planes are required. And also one useful sequence is DWI, and this sequence helps us to differentiate benign lesions from malignant lesions based on ABS values. Of course, DWI in skull base is quite challenging, and it's really difficult to get good images. So we try to employ different DWI. On skull base, we try to use non-PI, non-equiplanar DWI, and then we can omit some terrible sustainability artifacts. Okay? And when it comes to visualization of cranial nerves, we usually use a high-resolution picture. This is Fiesta 5-star drive. I also prefer 3D post-contrast sequence, which is a very thin sequence and allows us to precisely assess small structures on the skull base. Yeah? And if possible, please use 3 Tesla MRI machines because then you get better images. And when it comes to follow-up, first post-treatment study should be so-called baseline study should be performed 4 to 6 weeks after surgery and 8 weeks after radiotherapy. And extremely important is the information about treatment procedures that were used in this section. And it is very, very important to compare actual examination with previous examination. I mean, with baseline examination, with preoperative examinations, and because many characteristic features of the tumors may overlap, it is extremely important to know very precisely the anatomy of the skull base. As far as I know, this session is dedicated to students and young doctors, so just a short anatomy overview, if it's possible. Okay. I just want to remind you that we have 3 contour regions in skull base. Yes, anterior, central, and posterior skull base. That we have some foramina on the skull base, which are exit and entry points for nerves, veins, and arteries. And they have, and on CT, we can see only those bony canals and foramina. But we cannot assess they will content. And with the content, we can assess only on the mark. And this is easy. Okay, there's no definitive system for categorization of skull-based tumors, but there are some, let's say, typical for each region tumors. Yeah? For anterior skull-based, for central skull-based, for posterior skull-based, but there are some regions that can happen anywhere in the skull-based. Of course, this slide looks quite open, but I'm going to present only some most important, most frequent regions. Okay? Okay. And the first tumor I would like to talk about is the olfactory neuroblastoma, also called esthesia neuroblastoma. This is typical anterior skull-based tumor, arises from olfactory neuroepithelium located in superior olfactory recess. And essentially, kills ethmoid cells, and when it's getting bigger, it can invade into intracranial, into the brain. Okay? And then through the ethmoid tubular plate can go to intracranial, to anterior skull plate. This is called anterior cranial fossa. And this is here. And you can see some bone destruction associated with this tumor. Second tumor, it's also quite typical, is juvenile angiofibroma. This tumor is located in posterior nasal cavity near sphenopalatine foramen from the vascular, primitive vascular tissue. Okay, so this is vascular tumor, and it has typical features, so it has typical features. On picture we can see some flowers, those letterbox, and it is enhancing ALD, and it sometimes causes remodeling or even sometimes reconstruction. And when you see such lesions and such features, you know, peripalatine fossa, nasal cavity, think it's enhancing think of angiofibroma. Okay? Difficult to talk about images without images. So, I'll give you a break. Okay. Next group of lesions are finalized malignancies that can invade anterior cranial fossa. In this group, we have many tumors, many neoplasms. Squamous cell carcinoma, adenocarcinoma, squamous cell undifferentiated carcinoma, adenoid cystic carcinoma, and so on and so forth and so on. Okay? But the most often is squamous cell carcinoma, and this lesion is mainly located, this picture starts mainly from the maxillary antrum, and then goes up and to the neighbor of surrounding structures. Okay? And when I see picture like this, what I think of, okay, there's an aggressive mass located in the nasal cavity, there's the palatine fossa, there's the reclined sinus, with some aggressive bone destruction. And this is everything what I think of. I cannot differentiate. Is it squamous cell carcinoma, or is it adenocarcinoma, or is it adenoid cystic carcinoma? I can guess, I can give like version, but final like diagnosis is not me. It is responsibility of pathology. And my task is to describe it and to tell, okay, this is the best surgical approach for biopsy. If you want to know what is it exactly, of course you want to know because it changes things. Okay, so when we talk about malignancies, please don't forget about the perineal spread. Professor Szymanski talked about about the proper approach for some perinatal spread, but I would like to say that I would like to show one case. This is a lady, 67-year-old lady, 5 years after aortic gland surgery for adenoid cystic carcinoma. And this patient had some 5 years after surgery, had some ear pain, so the curiosity was performed. It's not visible here, but tympanic cavities were okay, ossicles were okay, everything was okay, but not exactly. We had some fluid, but not much plastic cells on the left. And what is more, take a look at radiant. Okay, you can see. There's a difference. This one is wider than this. Okay, it happens. Asymmetry happens in human body. Okay, but take a look. Okay. There's asymmetry. Okay, and in patient with suction history, with left aorticectomy for adenoid cystic carcinoma, it is always suspicious that performed MR. And what we have here, we have infiltration in mastoid area, in mastoid space, and perineal spread. Yeah, this is okay. This is perineal spread. Remember about perineal spread. And it happens in adenoid cystic carcinoma quite often. It's 65%. But it also happens in squamous cell carcinoma, it happens in melanoma, it happens in lymphoma. Okay? Most often involving nerves are 57. And there's not very big, it's like consciousness even in radiology about perineal spread. Still, there's a lot of mistakes and actually not underdiagnosed perineal spread. Okay? Okay, let's move on to the central surveys. And the most common central mass central surveys is intradermal microadenoma. This tumor has quite typical appearance. Arising gland, it's large and cause some compression, and sometimes some invasion. And this is benign, so it causes pulmonary modeling rather than destruction. And what you see is cells kind of spiral and walls out through. Okay? So this is the critical okay. If we go a bit lower to the clivus and sphenooccipital symptom release, there's typical tumor which arises from autogrowth remnants, and this is chordoma, which causes living bone destruction on the CT here, and typically negative is high signal on B2 and not very enhancement. Strong enhancement. Okay. Next lesion, the most frequent lesion about internal acoustic is in cerebral angle, is internal acoustic canal schwannoma, and this lesion causes smooth, is benign, arises from Schwann cells which wraps cranial nerves, which wraps actually not cranial nerve, but nerves, and it has typical, so it causes smooth internal acoustic canal widening, and and on MR, we can see typical eyes and bone appearance. Okay? And in 50% of those tumors, we can see cysts, and it corresponds with Anthony B. pattern seen under microscope. Okay? Of course, schwannoma may happen anywhere around any nerve. So we see schwannomas around trigeminal nerve, and often we see schwannomas in not very often, but it happens that we see schwannomas in jugular foramen. And again, it's jugular uniformly enhanced lesion with smooth jugular foramen enlargement. Okay? And this peak is quite typical and often seen in schwannomas. It's maybe not pathognomonic, but when you can see such peak and symmetry of enlargement and then this of schwannoma. And it's type of enhancement, of course. Because the first, the number one tumor of longus of tuberous foramen is longitudinal paraganglioma. And this lesion might be depressed. So, on the paper, appearance on the tumor with manifold voids because it's high vascular tumor, and it has AV enhancement and cause permeative destruction of bones. If this lesion grows in the paraganglioma, don't forget to mention it because it's very important for in this surgery. Okay, and meningioma is a lesion that may arise in any part of the sideways. And this is reason that it arises from meninges, it's an excellent lesion. It usually causes underlying bone fibrosis and it presents confidence enhancement and broad pain. Because again, it's attached to the blood. That's only some consideration. Okay, so the next case, this is a 36-year-old lady with lesion located in pituitary fossa. And what she's a kid. Take a look. Is it quite the same pituitary fossa? This is posterior wall of the solar plexus, and it has some hyperstones. It has also some hyperstones. Okay, what else? Take a look. On the center, pituitary gland is moving forward. It is not macroadenoma. It is also meningioma. Okay? So sometimes, as I said, those typical features may overlap. Okay? It's not always so obvious. At this survey, you can see also metastases, of course. Very often breast, lung, prostate. Sometimes we see some infiltration of squamous cell carcinoma, intestinal as malignancies. Sometimes we see myeloma, plasmacytoma. And looking at those features, I cannot say it's, breast metastasis. It's all. I can say, okay, there is a little lesion located at the elbows with some infiltration into hepatic sinuses, but I need clinical information. What kind of tumor is it? And then I can do better prevention, or I need, or I can tell how this lesion is spreading, and what other, if the primary focus is not unknown, what other imaging we should decide in order to solve what kind of disease is it. What kind of disease is it. Okay? And there are two last cases. On the left, 68-year-old female. On the right, 44-year-old female. Okay? Both with V1 and V2 neural deficits. Okay, what is this? There is some mass in covered sinus and going to macrophage. I don't know. Nothing more. I should give you some clinical information, please. And, okay, first lady, hard to get before cancer 2 years ago. Okay, then let's perform MR of the neck. Yes, but it might be renal recurrence. And as a matter of fact, it was. Because take a look. It's not only lesion here, but look at facial nerve. It's also here, and it's going to put on also. Okay? So it is renal recurrence in patient 3 years after carotidectomy from throat cancer. Okay? And on the right, the main complaint of the patient was cough and dyspnea. And so we decided to perform chest CT. Okay? Chest CT. Okay, this is medicinal, I don't know how. What is it? It might be sarcoidosis. See? And as a matter of fact, of course, some laboratory tests were done, and it was sarcoidosis. And 2 months later, the same lady from Peru, after steroids, the lesion almost disappeared. Okay? So it's really something. Okay, so we always in clinical context. If you want to give some final diagnosis or even diagnosis. Okay? And my last slide is, I hope, I convinced you that imaging provides information, location, and extension of vision, and that CT and MR are complementary examinations. and that clinical information is extremely important for differential diagnosis, final diagnosis, and for follow-up. As Professor Kowal said, patient wants to know, should have correct information about the tumor test. Okay, so this is our role, but we need information. Okay, and that is that we always have to compare actual examination with the previous examination. Baseline examination with surgical examination. It's really important. Okay, and I should say mission accomplished, but I think I have some questions that as well as after.
Thank you very much for this nice and comprehensive overview of the radiologic findings, CT and MRI. Are there questions from the audience?
More and more patients with minor lesions are managed with waiting scan policy. After first two MRI, we know there is a tumor that is probably primary tumor, and the question is it wrong or not? And my question is it always needed? Is it obligatory to give the patient contrast for each examination, or we can maybe resign from this option if we only assess the size of the tumor?
Okay, so when it comes to schwannomas, it's usually, there's still debate in radiology environment if use contrast or not. But there are many departments that only just use CIS or Fiesta or dry and just observe the large of the lesion. Yeah, when it comes to internal auditory canal schwannoma. But when it comes to skull-based lesions, we are always very, how to say, careful. Because, when you have, let's say, you think it's arrested pneumatization, yes? And you think, okay, it looks like arrested pneumatization, but you are not very sure because there is some cortical distraction, and and then, okay, so maybe it's echorodosis fistulifera, okay, and if it's, let's say, echorodosis fistulifera, then it's always a question, is it still echorodosis or is it changing maybe to chordoma? I don't know. That's why, we are, how to say, very careful. We don't see patients, we usually don't know their symptoms, and that's why I think we always try to use contrast. But in schwannomas, in acoustic, internal acoustic canal, I think it's not. But this is my personal opinion. I know that it's different in different departments.
I also know this procedure, if you have the first scan, this transformation following without
Yes. Yes, but it always depends on the type of work.
Thank you very much. If you kindly allow 2 questions, please. Do you think it's feasible and practicable to apply some diffusion or traction and DTI techniques to locate the nerve fibers of the facial nerve in schwannomas to guide the surgeon? And the second question, is there any tricks to assess before surgery the density of meningioma? Would it be suckable or firm to guide the planning? Thank you.
Okay, so first question. Sorry, I forgot the question. Okay, no, it was about DTI, sorry. Sleepy, sorry. But when it comes to DTI, I know there are some studies about it, and there are some departments that perform it. I don't have my personal experience in schwannomas to use DTI, but it is technically possible. Yes, it depends on the size of the tumor, and it's always depends on the size of. If it's not very big, in free Tesla we can see really nicely all nerves. if it's small, let's say from schwannoma, from ganglion of Scarpa, yes, we can see really nicely each cranial nerve, You know, we see facial nerve, we see vestibular nerves, we see cochlear nerves. So it's, yeah, but when it's bigger, I know some people perform it, but I don't have personal experience. And the second question was density. Density we can always examine on CT, yes, in the system. Because there we have, this region of interest, and we can just, put this region of interest.
This is a certain question I want to ask Same. Whether the tumor is very fibrotic, and therefore it is much more effective for the surgeon to take out the tumor, or whether it is more soft and you can sacrifice use the juice or something else to get the tumor reduced, as the tumor reduced and take it out. So there is radiological design for the MRI which can give some hints of this elasticity or strength.
Yes, I think that on DWI we see if the tumor is getting densely packed or not, because diffusion weighted images is a sequence that shows us the diffusion of some particles, yes, and if it's densely packed, this diffusion is, more restricted. If it's loosely packed, it's not so much restricted. The same with enhancement. If it's fibrotic, it is not enhancing so strong as this, other types of meningiomas. So I think it's possible. It's not, how to say, it is only, it's not quantification, quantified assessment, but rather, just quality assessment. Yes, quality assessment. Yes. And it's always a chance to do it on MDTs. We have MDTs every week. So.
But the abscesses are restricted too.
Pardon?
The abscess is also restricted.
Yes, but yes, of course. But if we have typical features for meningioma, I mean, it is located near dura. It has some dural tail, and it enhances strongly. There's no fluid inside, okay? Then I think of, and I have CT and I see hyperosmosis. It is very probable that it's just meningioma, yes? And the abscess has totally different imaging features.
The clues. Sometimes you see it, but it's not restricted, but on the operation it's really worse.
Yes, it sounds like a very interesting topic for a study.
Okay, I think we should close now this first part of our day today, and thank you very much for your contribution. One final remark, because it is very important to have clinical knowledge. The best thing to get this is to listen to the conferences of your established team, and then you have everything together. Thank you.
Thank you, Robert. So we have a break. We are a little out of time, but nevertheless we keep the break like in program, and then so we maybe will be a little fastest. But if not, we can stay here a little longer. It doesn't matter because it's Saturday. So thank you now, and we have a break. Please upload your presentation because that's the problem.
Lekcja zaczynała podłączyć, bo też mam Apple'a, ale przez HDMI, tak jak tutaj kolega stwierdził.
Myślę, że tak, że w ten sposób będzie można
Chyba najprościej.
tak.
Za dużo filmów, że taki nie było.
O, zdecydowanie. Ważne, żeby prezentacja przebiegła prawidłowo.
Myślę, że najprościej to będzie,
tak.
Mam prezentację tu.
Dobrze, okej. Dobrze. Myślę, że nie będzie problemu.
Wtedy bezpośrednio do tego.
Tak. Tutaj koledzy specjalne techniki przesłuchania.
Są jeszcze technika na podłodze.
Jest. Dużo tych kabelów. Just and we will check very quick. Michał, możemy sprawdzić wszystkie komputery, czy działają? A nie możesz ty tego zrobić?
Mogę, tylko nie wiem na komputerze, tak uwaga. Ale tak, coś
Time consuming. Profesor Łysy też będzie chciał prezentację. Docencie z komputera pokazał? Michał? Wiesz co, bo na przykład docent będzie pokazywał z pendrive'a.
Ale to już nie chcemy kombinować.
Ale to ten komputer może podłączymy wtedy, czy nie?
Możemy.
Dobra, to wtedy ten komputer podłączymy.
Albo jakiś komputer, który tu
Chyba nie możemy tak robić.
Okay.
Dobra, zaraz się zapytam.
A możemy sprawdzić, tu Office się otworzy nam? Znaczy w sensie prezentacja? Chyba tak. Przepraszam.
Tutaj mamy jakiś folder, prezentacja.
No, najpierw wrzucimy już do folderu.
To wykasujemy.
Zobaczę, czy to będzie ulać. To chyba rzeczywiście na moment. Jeszcze.
Can please you if there is something discussion about society, discuss with professors or something, because we have more than 1 hour delay, then I have a train, didn't count with this delay, and I have to be, yeah, so, I think...
Do you want to discuss something?
I don't need at this moment, but we were discussing, the chairman, the secretary, and things like that. I, really want to help you with that, but I, do not have enough time this afternoon to do it in the afternoon. So we can do it, online, or if there is anything to do it right now.
Project? What is connected to this?
Yeah, okay. Yeah, because I think I have to give you my fares in the afternoon because the train goes at 2:30, something like that. So it's all because I have to be in Prague till midnight. So in Prague. Okay. The copy Great.
Yes, you just have to be in a row, okay? We have to check if everything is... Yes, you just have to be in a row, okay? Almost. We have to check if everything is... Okay, we have to ask if there's possible to do that. Okay, we have to ask if there's possible to do that. Okay, thank you. Dzień dobry. Michał, my możemy z tego komputera tutaj wtedy go podłączyć, czy wam to wszystko siądzie?
Wiesz co, znaczy musimy mieć sterowanie z jakiegoś...
wy będziecie podłączali Maca w międzyczasie, to wam to wszystko siądzie, czy nie?
Znaczy, chcemy podłączyć z komputerów,
No, ale jak nie wszyscy mają komputery.
Tak,
No
co najmniej 2 osoby.
To do tego będziemy podłączali, tak?
Tak.
Dobra. I to nie, jakby nie popsuje tej...
Znaczy, wiecie co, to ja inaczej. Dam swój komputer.
No.
Dojazd do Warszawy od 4 rano zajmuje 2,5 godziny. Z Poznania do Centrum Zdrowia Dziecka. To jest nieprawdopodobne.
2,5? To chyba 200 na godzinę.
180.
Już ci.
Złoty. Możesz to podać? Albo sprawdzamy.
Wymierzyłem, że pojadę trochę dłużej i obudziłem anestezjologów tamtejszych.
No to proszę podejść. Mamy kwestię podłączenia Maca i mamy prezentację już na pendrive'a i do online. Ja mogę swój komputer udostępnić, ale pytanie, co z online'em?
Czy pan profesor też będzie z Maca?
Dobrze, możesz podejść? No to 30 sekund.
Pamiętacie, jak to się robiło?
Filmy?
No. We don't have the connector to
Mam konektory, wszystkie, które pan potrzebuje.
tak?
Wie pan, jak się zmienia, żeby
Bo
automatycznie
może być pełną przejściówką.
Wie pan co? Inaczej zrobimy. Ja zgram tego pendrive'a na ten komputer. Dobrze? I już tutaj idziemy. Dobrze?
Dobra, no to już go zgrałem tutaj.
Okej. Też?
Jest już zgrany, no to następny. To najwyżej poproszę kogoś, żeby mi wypuścił ten film, jak będzie stąd.
Ale to nie. No naprawdę, zgrajmy momencik. Bo pan... Momencik, to sekundkę, jeszcze poczekamy na ten Włodzimierz.
Dobrze, a kto z MacBooka będzie
Kto będzie pierwszy z
Może być z HDMI, może być z przejściówki.
A czy możemy pan na koniec?
Nie.
Jasne, możemy, nie ma problemu.
Ponieważ u nas system niekompatybilny z Maciem, ponieważ ten komputer jest...
Tak,
Dobrze,
profesor Jurwina nie będzie przypadkiem mówił z Maca, również będzie
tak,
mówił z Maca.
to czy możemy my Jurwiny na końcu...
Słuchaj, ale to strasznie skomplikujesz.
To nie jest skomplikowane, to jest...
Profesor Łysoń też będzie mówił z Maca i profesor Żułkowski.
No to Maca podłączymy z projektora. A poczekaj, inne prezentacje, nie przez Newline'a, tylko przez mojego dela.
Tak, okej. Tak będzie dobrze?
No jeśli będzie działało, to na pewno będzie dobrze.
Wszystko będzie działało.
Jeżeli to coś
Nie, bo te pierwsze prezentacje jakby mają
Przepraszam doktorze, ale czy pan się interesuje?
To są pokrywane prezentacje, w związku z tym tutaj...
A czy my możemy, panie docencie, my możemy pana prezentację tam od razu przełączyć. Czy pozwoli pan nam uruchomić system?
Nie, z Newline'a nie będziemy korzystać, bo będą Maci, nie będzie czasu na podłączenie. Będziemy z Newline'a
Dobra.
z Newline'a nie korzystamy. Czy jest HDMI? Czy mogę się HDMI włączyć? Tak.
Można się potestować tym?
Już, momencik, tu kabel. Kabel teraz jest, rozumiem, ten komputer, przepraszam bardzo.
Kludynko, proszę Ciebie tam pójść na przerwę, wypić kawę, pozwolić nam tutaj pracować, dobrze?
No właśnie, Włodek, skończ.
Podłączenie.
Skończ. Ja ci nie ruszam tego kabla. Nie ruszam ci tego kabla. I nie pójdę na przerwę.
Dobra, to już sobie idę.
Ale widzę, że działa. Dobra, cudownie. Dobra. Nie, spokojnie.
Костя, поглянь, будь ласка, куди йде цей кабель. Костя. А, gdzie Костя?
Dobra, wiecie co? Ja się poddaję. Będę prosił o opuszczenie filmu, dobra?
Tak.
Z tego. Mam nadzieję, że to się...
Tutaj na to?
Tak.
Nie łączy się.
Panie docencie, a można pana prezentację? Panie docencie, można pana...
Już piszę.
A można jeszcze... Pan zgrał to na ten tak? Tak. A można jeszcze to...
Dobra, ale to teraz tak, jak ją przerobiłem, a jest zgrana już na ten, to będę musiał je znowu przerabiać, tak?
No dobra, to możemy się tylko
No tak, zapraszam.
A może jeszcze raz pan zgrać na pena i dać mi prezentację?
Dobrze, już to robię.
Czyli tutaj, akurat tutaj wszystko gra, tak? Dobra. Nie, jest. To jest. Dobra, momencik. A, ten kabel trzeba skręcić, tak. Ale to nie, bo trzeba go zakręcone. Będzie. Zrobić to? Działa. Pięknie.
Sprawdzimy jeszcze tylko Dela, tak? Bo mamy dwa maki.
Nie, jeszcze jest jeden mak.
A, okej. No dobrze. No to poczekamy na profesora, tak? Czy że będę musiał wskoczyć?
Nie. Ja spróbuję tylko rozkręcić. Skręcana. Całą imprezę. Dobra. Teraz powinno być. Tak, teraz powinno być dobrze.
You have longer cable? Zaraz muszę kabel.
Ale nie, jest, powinno być dobrze. Zobacz, jak jest rozkręcony teraz, to zyskaliśmy te 15 sekund. Dobra, cudownie.
Teraz sprawdzę.
Drugi działa. Jeszcze trzeba będzie tej dziewczynki.
Nie.
Tej Diny.
Co? Nie, to teraz to już...
Nie, to jest dobrze. Teraz nam starczy.
Dina też ma maka, czy nie?
Nie, Dina ma Adela.
Nie, jest
Okej, no to tam się przegra normalnie.
Na twoim echo będzie Vicentego Kliba i kogo jeszcze?
Nie wiem, kto z projektu? Może z Pendrive.
Kto będzie z projektem jeszcze?
To są profesor Niemczyk
I profesor Niemczyk. Dobra.
after the conference we are going to visit Warsaw.
Wowa, jakie wydanie?
Martin and
Nie zdjimaj nożu. Kiedy jest?
To przy chodzeniu nie boli. Weźmy buchniki.
Jeszcze okazję, daj
I? No dobra.
Rozchodzimy.
Rozchodzimy.
Martin also as I. He is the same stature as I, the same expression as me, so we are almost alike. And so I think of this presentation as an adjunct to his presentation, and I think they are complementary, not contradictory. So this I will try in my presentation, shed anterior lines to the same for the notes. So, what we call parapharyngeal space. This is one awful space that is located between the parapharyngeal wall and roughly, but I would not go deep in the anatomy. I don't see any reasons for that, and you should not always remember the basic things. If you know that it's the space between, if you can imagine yourself presenting your head in the space between the pharyngeal wall and infratemporal fossa, then you are presenting yourself exactly the parapharyngeal space. No matter of the structures, 10, 15 structures that you might or might not remember. This is a very important thing that it is the styloid diaphragm divided into pre-styloid, which is essentially carotid sheath and contents, and low cranial layers. No, post-styloid, sorry, this is wrong. That is post-styloid and pre-styloid contains head and heart tissue, muscles, vessels, and nerves. Excuse me for this mistake, this is my space. Where it reads pre-styloid, when it says pre-styloid, read post-styloid. When it reads post-styloid, reads pre-styloid. This is my mistake.
considering the surgical approaches, Martin has beautifully described fish like sea masters this space perfectly in accordance to following the carotid artery and orienting itself to the cranial nerve and vessels orifices in the skull base. Then we have standard transvestibular transmaxillary mid-faceted laving. It is a standard that is very vague and a very inadequate approach for this problem. And then another lateral infratemporal approach on the lateral side is extending transmandibular. When you section mandibula not permanently but temporarily, and then open the space widely, do the surgery, and then assemble mandible back. And then in the last few years, endoscopic approach has reached this area. We have becoming so bolder and bolder with the advent of technology and involvement of technologies. We have been able to spread our entrance and our possibilities of work even in so dangerous and unpleasant space. Considering a surgical approach, the point of entry and the control of everything is maxillary sinus and pterygoid plates. This is the main point of entry and the main point of our interest. We go posteriorly, from anterior through the maxillary sinus, along the pterygoid plates posteriorly. What do we find? First, we found pterygopalatine and pterygomaxillary fossa. This is an entrance door. There are virtual spaces, but they widely communicate to the space which you want to master and do some surgery in. What do we find? We're finding very annoying structures that bleeds, that are really tedious to manipulate with, and also in combination with this bleeds. Then this bleeds a lot, and then this bleeds a very lot. And then, if we are not clever, if we are we get lost. We can go even outside and hit the orbit, hit the cavernous sinus, and hit the middle fossa structures. That's not good. That's not good. Then you have a serious problem. Then you have serious complications. So this is a very dangerous surgery. This is the point of entry. The pterygomaxillary and pterygopalatine spaces are located immediately after the posterior wall of the maxilla, and this is the zone which we force to enter in a quality way to this region we want to operate in. It's in fact a virtual space, and those spaces that they have a wide communication to those intertemporal parapharyngeal spaces and then neck spaces. What can we say about the anterior roots, which we will now be? Well, this is a parapharyngeal space with still one branch divided posterior, there is carotid, there is cranial nerves, and there is internal vein, and some structures located behind the deep fascia of the neck, like a sympathetic chain, and some lymph nodes. So those are usually pathologies that you can find in posterior space. Peristeal space is a wide space and with a lot of pathology. Unfortunately, the majority of them can be big. Which is our point of entry. Our main pointer and orienting marks are pterygoid plates, which are located immediately after the maxillary sinus. It's essentially communication or synastosis between the maxilla and sigmoid bone. We go through the posterior wall in this direction. So the space we can cover is relatively small. It is not wide because this is very narrow. We have 2 points of restriction. First point is anterior point when we enter, so our manipulating angle is very low. It's not so big. And then the second point where we are restricted is a small exit through the posterior wall or posterolateral wall. If you are balding, go also in the lateral wall. But it is still very narrow, second narrowing. Even narrower. So our angle is quite restricted. So we cannot
space. And we are very, very reluctant to control the carotid space here, the space of the carotid sheet, because it's to us a little on the lateral side of our surgical field. This is the green line for orientations. We also orient, like in the fish, the same structures. The greater ring of the sphenoid bone, the foramen ovale, foramen spinosa. The yellow line is actin 2, but we are dealing with the cartilaginous part. Martin 2 deals with the osseous part. So that's the skills first, and then he comes to the cartilaginous part, and Martin 1 goes from cartilaginous part. If he is involved to the osseous part, it's very dangerous because there is a red zone, a posterior space around the carotid and controls part of the carotid artery. What's from the lateral route, which Martin has beautifully described, I will not repeat him. The essentials are like this. Also, you go from the lateral side, your points of orientations are glenoid fossa, then the foramen spinosum, just opposite, then foramen ovale, then you hit the pterygoid blade. You have to orient yourself. There is final orientations of pterygoid blades from the lateral route. There is a wider area of working, but nevertheless you sacrifice a lot of structures temporarily or permanently. This is the orientation line, the green line, glenoid fossa or styloid. Glenoid fossa, foramen spinosum, foramen ovale, and then the zone of the pterygoid blades. The yellow one goes through the styloid or foramen ovale and pterygoid plates, and behind is red. But you deliberately transpetrosally go to the red zone, and then from the red zone, when you are safe, you are easily mastering the green zone and the field you are working. The problem is that this field for intertemporal approach is a little bit untidy and unpleasant to work with. And for us, anterior is vice versa. But we have to have equipment. That's what I said at the beginning. The first equipment is how to navigate ourselves. If you are very smart, you don't need navigation. I'm not so smart because I like to have navigation at this point. Also, I navigate myself first. First, you have to navigate yourself. The computer won't help you if you get lost because you don't know where you are and you don't know how to use the information the computer is giving you. So first we have to give orientation for yourself. And then we have to have instruments. This is the instruments I've been using for 15 years. I think I've been the first man to ever use this device in the skull base. It is a harmonic scalpel, ultrasound cutting and sealing device which cuts and seals beautifully small vessels and coagulates them, and it is devised for endoscopic gallbladder and liver surgery. So in this regard, it's extremely efficient and can be used in skull-based procedures. This one can be used only in an open. What are the contraindications for endoscopic approach? Well, vice versa, again from the Martin presentation. Maximization of the intertemporal muscular space, which are main indications for his approach, are main contraindications for my approach. Bone invasion. I can barely tolerate the elbow process because I'm leaning toward the maxillary, but I can barely tolerate the palatal bone invasion because I'm leaning towards the palatal maxillary. And I can barely control massive invasion of middle cranial fossa and base. Maybe from the zone of the middle fossa medially to the foramen ovale, but laterally to the foramen ovale. A definitely endoscopic approach is not a tool to deal with. And for those pathologists, the fish approach is actually what it has been designed for. So, when you go roughly inferiorly, the more inferiorly, the more laterally you go, and the more maxilla it takes, you cannot count the endoscopic approach is an approach that you should use. You should avoid it. These are a few cases that have been operated by endoscopic transnasal transmaxillary approach. You see this is a lesion in a young girl, 14 years of age, located in the cavernous sinus. It looked like it was actually cavernous located, and in the zone of the greater ligament sphenoid bone. Yes, we can approach it transtemporal and intertemporal approach, but then you will have to lift the brain a lot. It is a young girl, and it doesn't seem to be malignant in its origin, and it is very nicely located immediately behind the posterior wall of the maxilla, so I opt for an endoscopic approach. And this is the operation. Harmonic case, you see I cut the turbinate, the middle turbinate. You see the essential point is wide arthroscopy and wide sphenoidotomy. The presentation of the posterior wall, you see, and then location of the sphenopalatine artery. We have been dissecting and locating the sphenopalatine artery after SME, and then follow the sphenopalatine artery, and you see this is actually the pterygomaxillary pterygopalatine fossa. You see the muscles and the soft tissue, how they easily are cut and very dryly cut with this device, and then just peel the muscles and the tissue off the greater ligament of the sphenoid bone. This is the brief bleeding from the sphenopalatine artery. I just put a clip, drill the greater ligament of the sphenoid bone, enter the problem, and you see now it's an epidermal cyst. I widen the inferior lateral recess of the sphenoid sinus to get a better control towards the cavernous sinus, empty the contents of the cyst, and then I try to peel the envelope, the capsule of the cyst, and this is a presentation of the mandibular nerve exiting the skull base, and this is behind the dura of the lateral skull base. This is the sphenopalatine artery, and clear field, this is sphenoid. Clear field at the end of the operation. She went uneventful, there was no approach trauma, and she was dismissed on the 4th day home. This is another case, an interesting case. There was a man that was 2 years before operated on basal squamous cell of carcinoma of the larynx, supralaryngeal region. And then he got metastatic disease. It was biopsied, and it was the same tumor that he had in the larynx. Unfortunately, he had synchronous 3 processes in lungs, which was suspected to be metastatic diseases. So we opted for one quality palliative procedure. Pterygopalatine area, you see this is a narrow one. On this side it is a broad one, but you don't see the exiting of the tumor actually, but you see that there is invasion here towards the parapharyngeal space and pterygoid space with pterygoid muscles. So we have to perform a little bit wider approach, and again it's looking at anterior skull base. Although on the majority of the skull base there are no bone erosion, but in one place, posterior to the ethmoid, there was an obvious lack of bone signal in the anterior skull base. Since it was considered to be a palliative procedure, we didn't count in advance to take down the anterior skull base, because we thought that the risk of complication if we were to perform a transnasal craniectomy far exceeded the life expectancy of this patient, so we decided that we would stay extradurally all the time and try to solve the disease. You see, that's what I've been talking about. Broken pterygopalatine space. This is the procedure. So we started with the blocking of the tumor with microperiod to orient ourselves. This is the bottom. Presentation of the skull base.
And yes, there was a zone, evident zone of the dura, the histings of the anterior skull base, you see. And then we performed the section of the lamina papyracea and drilling of the lamina papyracea in the zone near to the orbital apex, drilling of the anterior skull base to the dura. And then we presented the origin of the tumor on the lateral, actually in the sphenopalatine foramen. Then we taken down the posterior wall of the sphenic sinus, isolated the sphenopalatine artery, then we drilled, this is our pointer, the plates of the pterygoid plates, and after drilling the pterygoid plates, this is the zone of Eustachian tube, and this is the pterygoid muscles. And with this instrument, I can do and block resection of the pterygoid muscles how much I need. How much laterally I want, I can, with this instrument, in a dry manner, completely in a three-dimensional way, cut the contents of the pterygoid space. You see there is no bleeding. This is a live video with no shortening. This is actual procedure. And this is the orifice of the tumor. You see, at the end of the procedure, the muscles have medialized themselves, and then you will see this is the intraoperative navigation. Why I need navigation? To see how much of the problem I have taken out. I have taken almost 2 centimeters laterally from this broadening of the pterygopalatine space, pterygomaxillary space. So I thought it was enough, and it still was enough because the patient went well. This is his image a year and a half after surgery. He received chemotherapy for lung disease, and then the lung metastasis resolved. It is now questionable if there were at all lung metastases. And he had no local recurrence whatsoever. And this is his post-operative presentation, let's say about a year after surgery. He suffered laryngeal stenosis due to prior surgery. And I lost him to follow up at 3.5 years after the surgery, partially probably because I moved from the department that I was working on when I operated this. Maybe he is still alive, maybe he isn't, but you will be on my side at 3.5 years of the quality of life pays itself off for this kind of procedure on this kind of pathology. And now the third patient. This is a vast tumor that came to my office by an accident. It was pronounced to be chordoma, and a big stent had been put under the diagnosis in another institution. Then radio-oncologist, radiotherapist in oncology said, Martin, can you please help me? This lady cannot lie on her back because I cannot irradiate her. She cannot be calm because she can't breathe. She has nasal pharynx full of tumor. Can you reduce this? Is chordoma. I'm going to irradiate her just radiated that she will die anyhow, but please just do a little reduction. And this didn't look to me like a chordoma, so I made a biopsy, and then I put my pathologist in a big trouble. She didn't know what it was. They first suspected the tumor from the kidney, so we made the abdominal checkup, but there was no kidney tumor. Then she sent the specimens for second and third opinion, and then at the end came out and turned out to be a clear cell tumor, clear cell carcinoma of salivary origin of the parapharyngeal space, invading with the beginning of the invasion of the middle skull base, and with the close relationships with the floor of the cavernous sinus on the ipsilateral side, and with a huge advanced involvement of parapharyngeal structures. And then we opted, because of the location, we opted, again, it was quite good located for endoscopic approach, except for this closeness and vicinity of the carotid artery. But nevertheless, we tried.
This is like a extended approach, transnasal and transmaxillary endoscopic approach to the parapharyngeal space. This is the essential steps of the procedure. So again, spheroidectomy, large antrostomy, presentation of the posterior wall of the axillary sinus, presentation and location is the triangular echoing process of the palatal bone, and then following the artery, clipping of the artery, and you see dry, and then wide resection of the parapharyngeal and pterygoid spaces, allocation of the pterygoid plates, drilling the whole pterygoid plates in the height and in the width and anterior posteriorly. You see complete resection of the pterygoid plates, and after that you should get to the Eustachian tube. This is Eustachian tube invaded by the tube. You see, this is the fibrous ring. This is cartilage of the Eustachian tube. Then we remove the cartilage up to the bone, and then we presented the tumor. We did a little bit wider lateral resection, so we present the tumor. We have been able to dissect the tumor in almost its entirety. And we left only several millimeters of the tumor. This is you see the skull base, the lateral ring of the sphenoid bone, and there you will at the end see the oval foramen. This is the area I feel secure. And this is post-operative, at the end of the operation, post-operative state. She was irradiated post-operatively, and she is alive and well without recurrence at a 4.5, almost 5-year follow-up. This is her post-operative CT, and this is her aspect post-operative. I put a rope about the presented with carotid artery and put a line around the vessel in order to be able to close it in the case of carotid blowout during the operation. What can we say about limitations? So I told you before, inferior, lateral, invalid moment of the maxilla are contraindications, strict contraindications to this technique. But maybe we can do some improvements in inferior and lateral plane, or in skull. Recently I had one patient that forced me to do the transoral and transmaxillary. They had bilateral recurrence of the huge recurrences of the chordoma that was in control in the clavicle region that exploded in the parapharyngeal spaces. And what I have thought, this is the skull. Usually when we go, I told you that we have problems with carotid orientation, all the parapharyngeal carotid. Recent reports and anatomical studies always suggesting that a good orientation mark is this spine before lies just before the carotid canal. From next, and then what? It is very hard. It is easy to find this spine on the skull. It is not so difficult to find this spine on a cadaver, but it is extremely difficult to find this spine on a living human during the operation. So this is not useful landmark. Because of our roots that I have described to you, this is a point of entry. We have two restrictions throughout our way, and then very small angle movements, or possibility of angle movement. So we are forced to go lateral, and we have a lateral approach to the carotid. We have a combination of the lateral and anterior-posterior movements, and then we got lost in the area of these muscles, in the zone where you have no orientation. You got lost. You got lost, and you have no marks to orient yourself. And again, you're coming from a side, then so you have no orientation whatsoever. The best is when you come from a lateral or from anterior, but when you go in the frontal way, when you don't have angle to follow, but you go at 0, or you can say 180 degrees, with a 0 angle, when you approach the structure, then you're most safe in your mind, because your mind setting prevents you from calculating the angles between two angles if you go, if you're coming from left to right. And then this area is poorly covered, very poorly covered with normal breach, today's breach, transmaxillary approach, the transmaxillary standard approach, endoscopic approach to this area. So I thought, what about taking down this part of the maxilla? Yes? How? Maybe I should try. And then I would have a route like this. I would have no two stenotic places for entrance. I would have one wide approach, only one channel of one point of stenotic point at my approach route. We will not have to nostrils or drilling or hole in the anterior maxillary wall and small hole in the posterior maxillary wall. I have only one hole, and I would perhaps have wider exposure. So I did. I used a usual level 1 osteotomy with my professor Alina. She suggested me. She's very skilled, now retired, but partially retired maxillofacial surgeon. She said, why can we do a down fracture? So there is an incision, bone incision, and the prior plating with L plate and with one normal plate, and then extending this bone incision posteriorly, and this is the only tricky part. You have to make a blind osteotomy to separate pterygomaxillar synostosis. But it is not so complicated. And then comes another issue what kind of maxilla would you want to take down? The 3 teeth are the minimum. Less than that, you have no reason to do this kind of a surgery. But if you need more, you can take more. You can take more. You can take more. You can take even a half maxilla. You can have a complete maxilla down, but there is no reason for doing that. And then you can do a sub-periosteal osteotomy on the palatal plate. You see like this, that follows the prior incisions, like this or like this. And then you have the segment of maxilla which goes down, and you have extremely large opening with which you just put the endoscope in. You can even drill the posterior wall of the maxilla to the alveolar process and widen your approach. And then, this is the patient. You see, there is a recurrences on the right side, a huge one, almost 5 centimeters. And this was a smaller, 3.5 centimeters, but located, you see, the palatal process is splitting the thing in two. So you cannot approach either transnasally, either transoral, because the palate is in your way. And then this one was operated by transoral approach. This is just a few moments of the operation to see how good you can use the endoscope transoral, strictly transoral. And it's getting more and more appreciated as one of the approach corridors for parapharyngeal surgery. You see, you open a pharyngeal wall, cross the pharyngeal wall, separate the muscles. There is a separation of the muscles. And then presentation of the tumor. You see the tumor is the last muscle bundles are here. And then you are presenting the tumor, and you are dissecting around the tumor, and using the traction to the soft tissues of the pharynx, and then you are freeing the parapharyngeal space. This is a tedious operation, but nevertheless can be performed. And then 3 weeks or 4 weeks after, I gave a main time to recover. I thought, it is foolish to perform both procedures at one time. This is it, incision, and then some periods of bone incision we have taken down, let's say it is a dangerous maxilla, which is good, and one would say, what is dangerous maxilla? Yes, we can put blood between the teeth, and if it's a malignant tumor, we can even take one teeth out, and then afterwards make an implantation. And this is patient after our surgeries. He has complete resection of the disease, and now he's waiting for a proton beam therapy. So, what can I say in the end? This can be very interesting. We are now undertaking anatomical studies on cadaver, and we will try to explore the potential of this approach. And I feel, during the operation, the potentials of this approach are enormous, and there should be the merits to be studied, and there merits to be evolved in all ways possible, because they are giving us possibility of direct approach to the carotid artery and perfect control of the most lateral aspects of the operating field, so that means of the lateral skull base towards the infratemporal space. So, what this is the man, how it looks like after the operations. Soon he looks perfect. No deficit, and he is living the perfect life now, and he will hopefully live for some time. This is not an easy surgery because you have to orient yourself. So, this is surgery definitely outside sinus boundaries. That is a sad fact because it's very dangerous. But you can help yourself. You have to be oriented. So, that is a good thing. Don't leave the cartilage and bone alone until very oriented, because and use the right approach for the adequate, for the specific pathology, and if arm yourself with appropriate tools. So I thank you very much for your attention. I'm open for any comments and questions. If there are any, if not, we have time starting.
Okay. So that's I can say the problem to that you show us relatively quite new approach to the parallel space. So of course, because we operate in many of these pathology, and I agree that this type of tumor which is frequently there, can be operated with endoscopic view and endoscopic tools. And we think that this approach is the best way for this, I can say, anterior part of in regard of the carotid artery position, location of the tumor, or you think that it can be so extended that we can try to manage even in another position of the pathology.
I was telling a few times when the pathology kisses your corridor, when it is not so far away from the corridor, then I think it's a good if you have courage, guts, and if you have tools, and if you have a feeling that you can encroach on the problem. You see, in malignant tumors, I do almost en bloc resection. I do reduction intranasal, but you cannot harm them. I reduce the tumor to the site of the corridors, insertion, and then the site of insertion, I have resected 3-dimensional en bloc. So this is very important. This is not a piecemeal resection. This is debulking and block resection of the tumor's insertion. And I can go as lateral as I would like. I tell you from my experience, I don't feel happy when I cross the foramen lateral. I feel that I am getting lost, that the carotid sits down there, and the sphenoid spine is not safe, not a good mark or pointer I can lean on.
So I need, in my hands and in my opinion, a better approach, not annual one, because when you are doing annual, you got lost. You have to calculate two variables, one transversal and one longitudinal, and then your calculator is not so good because and then muscle here, muscle there, and then you don't know where you are. And then if you go anterior or posterior, and in a lateral approach, you go against straight to the structure. You go forehead to the structure. You don't go behind them. Or if you go, you follow the bone. And I have nothing to follow here, because if I follow the bone, I will get on the petrosal part of the carotid, and I will blow the things away. And then I will sever the carotid and its actions. And in the parapharyngeal space, you can know whatsoever. And in this case, you can even ask for a steroid process laterally, and then immediately posteriorly it's a carotid. It has to be. It has to be. The only concern can be a nerve, patient nerve, which you can laterally and anteriorly sever during your orientation. Then it's a danger of the patient nerve if you're looking for bone orientation. But we can see, I think it merits a lot of skulls to be broken in this way and to be judged in a proper way. And then applied in multiple procedures, and then to judge if it is a good adjunct to the corridor that still exists, or it has to be abandoned completely, and it can be used from time to time. But it's good to know that it can be done this way. So when you think maybe your patient can be solved in this way, this was solved. This operation lasts, let's say, 3 hours, not more, because my Malinovich, she operates like a hell. You cannot follow her. But, yes.
Can I have just one question?
Yes.
Do you think with your experience there is still place for external anterior approaches like lateral anatomy or with facial design?
Dear Martin, I usually do not use the transfacial. Why? Because I always combine subperineal, subfrontal with any kind of. So I don't use facial split techniques unless the tumor has involved the skin or is so close to the skin that there is no use to use other approach. All other open transcranial approaches, I don't usually use transcranial, are legitimate. Lateral approaches are legitimate. Your approach is perfect, legitimate. Transmandibular, okay. If there is a really massive pathology with a huge volume, then not precise, any precise technique is good, because you cannot approach the tumor that close. If you have 20, 30, 40 square cubic centimeters of the tumor, then I think that piecemeal is very unpredictable, because somehow you got lost in your mindset depicting the whole pathology. Then you can do a transmandibular, which is the most brutal, but exposure is extremely high. And then you have the problems with the facial nerve, which is in your way. But you can have it. You can play with the facial nerve. Even you can sever it and then put it back together, counting with the patient, in concept with the patient, that yes, you will have a palsy, yes, you will have a deficit, definitely a deficit. Post-operative, you will have, let's say, 60, 70, 80% of the coverage. You will really need severing and then reassembling of the nerve. You will have at least 60, 70% of the coverage if you have done a good job and good orientation of the patient, or advanced orientation. But I completely agree. All approaches are legitimate, but you have to choose which is the best for the patient. My approach, I'm not advocate of the approach. Let alone I do all the lateral approaches. And I told the class I would like to learn petrosectomies to complete my approach from the lateral side, because at the time I'm using the services of my orthoneurologist. And I would like to learn at least a petrosectomy so I can work alone, okay? I will not do it tympanoplasties, I will not do it for the cancer surgery. I would like to learn petrosectomy in a correct way. That's
that's the reason, and that's my answer to the question. Yes. So, I cannot shut myself down. I will now call the Professor Lisa for endoscopic approaches to the orbital and skull-based pathologies. Now, he will go a little bit medial from me. Thank you for the invitation. I need to go back because I can see the market if you One more time, thank you for the invitation. I came from Białystok, which is the university center. I'm a surgeon working with a multidisciplinary team with my ENT colleague who is working with me for many, many years in the skull base. We have very good collaboration with ophthalmologists also and maxillofacial surgeons. So this is why for many years we are doing endoscopy in the skull base. As you can see where we are, it is 2 hours drive from northeast of Poland, deeply in the forest. And regarding endoscopy, all about endoscopy is how to transfer, how to change the superficially located lesion, the deeply located lesion into the superficially located lesion, because endoscopes gives such opportunity. So we have a lot of different approaches to the skull base and sagittal plane. We can reach from the frontal sinus to the down to the C2, C1, even it's possible. In coronal plane, we have a lot of approaches which are defined by the root of the carotid. And the beginning of this adventure with the skull base is pituitary surgery. So in the beginning, we started with pituitary. You can see the difference between microscopic view and endoscopic view, so definitely with endoscopes you can do much more. So, for instance, this is the tumor which is just hanging over the dorsum cella, and it was possible to remove this cellular part and finally retrieve the dorsum. And you cut the dorsal cella, and it was possible to follow the tumor, and finally we can go into the third ventricle. So you can see that in the Pismo method, I'm able to go into the ventricle. You can see it very well. And obviously, there's always a problem how to fix it, how to fix this defect. So we use the ADAPT vascular flap, which is put on the sternopalatal artery. Very good indication for this type of surgery is meningioma of the tubercle cell. So in this situation, we drill the bone on the bottom of the tumor. So in this way, we have already devascularized the tumor, and obviously we can remove it. The tumor is not too big, so it's relatively easy to remove this tumor from using this approach without touching any neural structures. And finally, on the end, you can see the chiasm, the carotid, and the ophthalmic artery going into the optic canal. This is retrochiasmatic chronic pharyngioma, also operated with this
method. We opened this is the typical cheeks head opening. You can see the chiasm here, and on the bottom there is a pituitary gland, and we find the corridor between just lateral to the stomach, and it was possible to remove this tumor almost completely because a piece of the capsule was necessary to leave in place. But finally, we have this patient is more than 10 years right now, and we have no regrowth of this tumor. So it was a very good choice for this operation. Also, no neural structures to be damaged. Also, we can go to the thymus or transpyral for other tumors like chordomas. We can go to the cavernous sinus, especially when you're operating. This is almost everyday practice when we have to operate laterally when the tumor, the adenoma is penetrating into the cavernous sinus. We can use angled optic that can look around the corner and remove the tumor completely. If we go a little bit lower, then we can see the paraclival segment of the carotid, and this is the route we can, because this is the thymus, we can go much more posteriorly, so we can get the pyramid, the apex of the pyramid, and then we can go even to the region of the jugular bone. This is an example of the cholesterol adenoma. As you see, this is almost in the posterior fossa, in the apex of the pyramid. And when we are drilling, this is the carotid uncovered in here, and we are drilling just around the capsule of the tumor, which is damaged right now, and we open this capsule, and it was possible to drain this pathology into the nasal cavity. Obviously, as you see, this is far, far away, so for this kind of surgery we needed very, very long tools and malleable tools, so we damaged all our sets of curates because it was necessary to bend it. And obviously, because it was mentioned already, we can approach sternopalacrine fossa, subtemporal fossa. We can also go into the middle fossa. So this is meningioma, partially in the sphenoid sinus, partially in the middle fossa. So we can remove this part which is inside the nose actually, and so I make it a bit quicker. So when we remove this part, then you can see the opening done by the tumor, which leads us to the middle fossa, so it was enlarged, and the tumor was also removed. And you can see this is a mid portion of the temporal lobe. And obviously it's necessary to fix it in watertight mode. So dura gem or dura form on the as the first layer, then this is the free graft, mucosal graft, and on the end a little bit of tackle seal, and finally the balloonage post this construction. And so this is obvious actually, because in many centers where the surgeons are performing this endovascular and endoscopic scoliotic surgery, it is an everyday practice. So now we'll change a little bit, and we will talk a little bit about something which is less obvious, about the orbit, because when you are entering to the nose, of course, you can change your direction and you can go into the orbit. So this was the beginning of our adventure with the orbit. As you see, this is typical opening, new surgical opening for the orbit. So we routinely approach from the ceiling of the orbit or laterally using Cronin approach. But it was many years we started to explore the orbit transnasally. Our first series was published in 2008, and this is very old case. This is purely intraorbital osteoma. Operated, as you see, the quality of picture is poor because it was an old-fashioned camera.
And this was possible after the ethmoidectomy. It was possible to remove the middle portion of the middle wall of the orbit and remove this tumor. Finally, we fixed this wall of the orbit with a cartilage taken from the nose. And again, after ethmoidectomy, this is the wooden stick, so this is post-traumatic case. And as you see, this wooden piece is just in the apex of the orbit. We made several operations like that already, and without additional damage of structures inside the orbit, and sometimes even with preserved vision, even if the piece of wood was nearby the optic nerve, like in this case. So, again, we have, this is the mid portion of the orbit also, the middle wall of the orbit is removed, and this is the tumor, which is still the tumor. And we can see, after taking a biopsy, that there is something inside, and these are wooden pieces, and this is the reason for this inflammatory tumor growth. So, the removal of these natural pieces is causing that after this surgery, the tumor is shrinking by itself because there's no irritating agent inside. Again, this is another wooden, another foreign body inside the orbit. So we are just pulling the middle rectus muscle right now. We are entering into the intracoronal space, and finally we found a metal piece which was there. It was not easy to remove it because it just stuck there, so it took time to take it away. But it was successful, and we performed many operations with foreign bodies using endoscopic techniques until now. So it was transethmoidal route, which looks very natural for these surgeons who are entering into this bodies through the nose. But it was not enough for us, because we wanted to have endoscopic approaches from every direction. So this is why we started to explore another compartments of the orbit. So now I'll talk a little bit about the inferior wall of the orbit. So this is operation performed for Grace Basadov. So that was the beginning. So we are creating a space for herniation of the fat from the orbit. So we perform a ethmoidectomy. Finally, in this case, because it was also ophthalmopathy, so we were performing decompression of the optic nerve in its bony channel, so it was removed. Finally, the middle wall of the orbit is open completely, so lamina papyracea was removed. And then we opened also the maxillary sinus. We are leaving a bar in here, just between the inferior and lower floor, the floor of the orbit, because we want to keep it in place. And now we have space, we can enter into the bottom of the orbit. This is one way to approach the bottom of the orbit. And we are cutting the periorbit and taking fat out of the orbit to decompress and to get some space. So this is middle of the orbit. So this was just an example, but to the bottom of the orbit we can get to maneuver, to do something, to perform surgery. We need at least 2 working channels. So this is why we suggest to use a cardboard approach, so through the maxilla. But we are performing very small opening just for one tool or for the optic. So this is very, very small opening. And now we have 2 corridors, or we can use binostril approach. So one way is we are going to the same nostril, and then we are creating a small opening in the septum of the nose, and transseptal approach. And then also we can put two tubes in different angles, so we can perform surgery. This technique was also published. And this is also an example how it works. This is a pseudotumor. Then there is something inside the tumor. So the idea was to take a biopsy or to remove the tumor. And while we took a little bit of this tissue, we found out that there is something inside. Obviously, it was a wooden stick. And we removed this because now it looks that there is nothing there, but when we are digging deeper, there is something there. And as you see, we have tools introduced from two different directions. So we can maneuver inside and we can perform the proper surgery. And this is this part of wood. And after removal of this, the tumor shrinks, so it was not necessary to remove it completely. So it was bottom of the orbit, and now, because we wanted to go laterally also with endoscopes, and we wanted to avoid cutting of the orbital ring. So we decided to introduce endoscope directly behind the orbital ring to the wall of the lateral wall of the orbit. So it's, I don't know, it's less difficult or more difficult, but because we were lazy and we didn't want to cut the bone, so it was for us it was easier. The only thing we are cutting is the skin and then fascia of the temporal muscle. We are not cutting the muscle at all. We are just elevating it. And then with a spatula, we are elevating the muscle, and then with a curved drill, we can approach far away to the superior orbital fissure, and even to the optic canal if you want to, in different pathologies. So we can see in this case it was hemangioma, relatively small tumor, and easy surgery. And this is Paget disease, as you see. This is an enlarged bone, and it was drilled very far away with the incision and brass, and we just decompressed the optic nerve, and the patient improved with vision after this kind of surgery. Sometimes the scar is almost not visible because this is 1 month after surgery, so the cosmetic is nice. So now we made a circle around the orbit. Now we are going to make another circle because we have another approaches. We adopted to the endoscopic technique. So 4 directions and 4 different operations. So in every direction actually we can move. So this is percaruncular approach. We are entering into the orbit and from there to the sphenoid sinus, and then it was the compression of the optic nerve. We can use a placental approach for interiorly located lesions. We can use lateral retrocanthal approach for laterally located lesions. So like in this case, it was a tumor which was completely resected because the narrow space is just on the surface where the eyeball is. And if we are going deeper into the orbit, we are creating space, so there is a lot of space there. So it's possible to remove even big pathologies. This is naturally made opening with a saw and a lot of such nasty stuff inside to remove. We did not make any harm to the function of the eye, and the vision was preserved, and the final results was also good. And as you see, with this technique, there was no remnants inside the orbit. And of course, we can go also through the superior eyelid, and many times we are using this approach also. But this is not the end. We can make another circle around the orbit with a transconjunctival approach. And this technique was also published already. And this is our first case with this technique. So this is the tumor which is attached in very close relation to the eyeball. So we decided to cut conjunctiva, like in this case. So we are cutting conjunctiva, elevating the conjunctiva flat, putting an endoscope behind the eyeball and following the tumor, and it was possible to remove it. This is the foreign body which pierced the eyeball and stuck just on the opposite side. And as you see, it's moving together with the eyeball. And we decided to use also this transconjunctival endoscopic technique. We put the endoscope behind the eyeball. This is the damage of the eyeball in here. We fixed it later on with the tahoe seal. And because with our tools we pushed this metal thing away, so we decided to use a small magnet because it was a piece from the metal hammer. So it was ferromagnetic, so it was possible to take it out without damaging at all, because the only thing to be cut is just conjunctiva. So in this case, we are making 3 times circle around the orbit, and we can approach in many directions. This is our how we are doing it. When the pathology is just in front of the orbit, we use this transconjunctival approach, especially for these lesions which are located nearby the eyeball. This superior eyelid crest or preceptor or precaruncular retrocanthal approaches we are using for peripheral lesions. And these openings through the nose, through the maxillary sinus, and this endoscopic lateral orbitotomy is dedicated rather for pathologies localized posteriorly. And we have very good results in very small morbidity. And we are just about preparing a publication, and we published right now. I checked that only pseudotumors since 20 years. We have about 50 cases, endoscopically operated about 50. So that's a lot. And I would like also to mention a little bit about safety of these endoscopic procedures, because everybody are happy that they are able to do this, but nobody is thinking if it's safe or not to perform this kind of surgery. Because we are, during these procedures, uncovering very fragile structures, nerves and brain. So we wanted to know what's going on inside the nose when we put the thermometer there. So we can see that during this procedure, the temperature inside the nose is elevating constantly. When you have a very long procedure for 3, 4, 5 hours, the temperature inside the nose is growing. And sometimes when our activity causes that this temperature is very, very high and dangerous for the brain. Sometimes the temperature of the operated field is about 41 at the end of the operation, plus minus 83, which is the mean temperature. So we can expect higher. This is what CUSA is doing. So CUSA is elevating temperature in our measurements 45 degrees. This is high-speed drill, very high temperature, potentially harmful for the brain. This is when the probe is on the opposite side of the bone. We are drilling the bone, and we put the electrode on the opposite side. So also high temperature. And this is cauterization of the meningioma, which was bleeding. And as you see, the temperature is going to be very high because of our activity. So this is one issue. So the temperature, and we need to think about it, and we need to cool our operated field. And also, we need to think about anesthesia, which is not really safe, because we want to have a bloodless operative field. When sometimes we see something like that, sometimes something like that, and sometimes we have very good conditions to perform surgery. And obviously we are asking constantly anesthesists just to slow down, we want to have a lower pressure because we cannot see anything. So we checked what is going on. So the middle cerebral artery velocity is going down, and as you see, this is mean arterial pressure about 80, and this is mean arterial pressure at 65, so the pressure is very, very low. And then we have bloodless operative field. We checked also, we inserted for huge operations, we inserted probe called Lycos. This is measurement of the oxygen within the brain tissue. And also we can see that sometimes it's a disaster because this is PTO2 levels almost permanently below the normal reference range. And also the blood flow velocity is very low. Cerebral perfusion pressure which need to be just higher than 65, sometimes going down. But this is one case. This is another where the Lipix actually permanently is out of the range. So if we have a long procedure, we need to think that that the brain is not properly filled and there's no oxygen within the brain, and also cerebral perfusion pressure is out of the range in almost whole the procedure. We checked also, there is a neurospecific analyzer, which is a marker of damage of brain tissue. And we found in some cases that after surgery we can expect elevation of this. So this is proof that the brain is damaged because of our surgery. So actually after surgery we do not expect any neurological findings, but definitely the brain is harmed. This is, I want to show you what we are using to have a safe surgery also in our department. We use the Doppler probe to find the carotid. I want to show you this is a disaster we've made many years ago. It was a tumor with bleeding, and it was just the first step of the operation. With the Harrison Roger, we pinched the carotid in this area. And it is also important in how to manage with this situation. We have an excellent interventional radiology department in our place. And fortunately, we did a angiography prior surgery, so we knew that there is a cross of flow, and then this is intraoperative video. When we put this cotonoid, we finished the operation from the nostril on the opposite side. We removed the tumor, but we put this cotonoid and the patient went down to the radiology department, and we wanted to check what's going on, why was such a bleeding. And we found out that it was a disaster because my colleague just put the balloon into the carotid, and finally we found that the carotid is completely damaged. You can see it right now. When we are taking this cotonoid out, the balloon is already filled, and you can see the carotid and balloon inside. So we decided to put a little bit of muscle over there and to compress this area, and we were waiting for the flow diverter, and it was also disaster during this procedure because it was one of the first procedure in our center when flow diverter was used. It was third or second flow diverter. So it was implanted in the wrong way, and as you see, this flow diverter caused that we have a stop of contrast in here, and the pseudo-aneurysm was fixed also with coils, but fortunately we had this crossing from the opposite side and the patient survived. So it was the worst disaster we ever had in our department in doing this kind of surgery. So it's good to have such cooperation also with our colleagues from other departments. So, concluding, I would say that nowadays we are making a step back because for many years we are doing a lot of endoscopies, and we were happy to do this operation. But nowadays we think that because conventional approaches are shrinking, they are very, very minimal invasive right now. Sometimes it's much better to do a conservative approach rather than endoscopy because you can. And definitely endoscopic surgery is not minimal invasive, and it's harmful for the brain. And if we want to do this operation, we need to make it quick, and definitely we need to make it with interdisciplinary. Thank you.
Thank you for this state-of-the-art presentation. Are there any questions?
So the first question, I really enjoyed your research on the measuring temperature during endoscopic and nasal
surgeries. And my first question is, since the temperature are increasing with the duration of the surgery, is it an argument to use dynamic endoscope holder instead of dynamic endoscopy by an assistant or an colleague?
In our center, we are using freehand technique. Obviously, we have many different holders. Also, we have a holder which is very movable and very nice. And but it's very rare we are using holder because
I could imagine that with a holder, the temperature would be higher in a setting.
Actually, there are many reasons to have this elevation of temperature. First of all, we are cleaning the mucus. The mucus is a cooler. Because there's blood there, and you have a cooling agent there. If you're peeling mucus, you have no cooler. And this is closed box, there's a lot of light, there's a lot of energy, there is drill, there is cauterization, so we have a lot of things which are elevating the temperature, despite we are constantly flushing the operating room.
Unfortunately, it's got to be a closure side. Pro targets would be longer than usually. That's the main disadvantage.
Yes, but you know, when we are entering to the training, this is the problem. Because when we are inside the motor, it's not a problem. But if we are opening all these neural structures, it becomes, we need to be aware that it's dangerous. And the problem is with everybody, everybody is not interested it's dangerous, because there's no clinical signs of it after this surgery. People are walking, moving. So, but if you are performing, I'm sure, 10 years later, MRI, you will see the shrinkage of the brain, like in people who are intoxicated with some it's my personal feeling, but I have no proof for that yet.
If I could have a second question, it's going to be controversial. Endoscopic flipping of the aneurysms, are we there yet or not?
I've been in Europe, I've been in Columbus, and the guys who are doing it, they are very, it's a bit different when you are doing it in Pittsburgh, a bit different if you are doing it in Yellowstone, because it's in the middle of nowhere. So if you have disaster in Pittsburgh, it's okay, it's Pittsburgh. If you have disaster in our town, you may have a problem. So I'm not as great as
Have you tried that for this time?
I've seen complex of the anterior communicating artery. It's very easy accessible, but I've never tried it. And as you know, probably there are several stages of endoscopy schemes, and on the end is vascular. So I'm not sure if I'm on there.
One remarkable way my photographic technologist, Acma Blanda, is also very nice to biopsy and to do his surgery. It gives itself like that. And I completely conclude with you that orbital decompression is absolutely good thing to do. The lateral.
Endoscopy gives a lot of free solutions. Nowadays, I think we have patients from all over Poland that come to us just to take a biopsy. Because sometimes to take a biopsy of a tumor which is localized very deeply, some surgeons they use proper openings for that. Because needle biopsy is impossible. So this is why endoscopy gives you new possibilities.
It gives new light in lacrimal surgery because the guidelines for lacrimal surgery for treatment of lacrimal gland are pretty good nowadays, and still for cerebral tumors, the pathology is for a small specimen biopsy or 5 biopsy can sometimes be wrong and guide you in a completely wrong direction considering the accuracy.
This is why we use a lot of different equipment, also with navigation. Actually, we use the same as you use, because we have optics, we have magnetics, and actually magnetic is the best.
Magnetic is the best, but neurosurgeons are reluctant to use magnetic because they always use optic, and
But it's, I can say it's almost impossible.
It's changing. It's changing.
When you are using optic, it's so crowded in this operating field.
I'm glad to hear that you're using magnetic because no surgeon in the world is at all optic.
Maybe this is why the friend of mine who was starting also with me in my department in this operation is the ET surgeon, and we are working together more than 15 years now. So
it's very nice that this cooperation. In Croatia, the neurosurgeon did not respect ENT surgery and maxillary operations at the level that is set OER. Okay, thank you very much again for this state-of-the-art lecture, and now we are moving.
Can I ask?
Oh, sorry.
Thank you for your presentation. What is the rate of complication of the endoscopic transformative?
Actually, when we were starting, so it was about more than 10 years ago, it was like that. When we started with transnasal approaches, there was no complications at all. And then we decided to go transconjunctivally. And we were so happy with this approach because it was so easy and so nice. And we were going deeper and deeper. And in two cases, after the second day after surgery, we had a complete damage. In two cases, but it was many years ago. And this is why we developed all of these different approaches. So each approach right now is for very precisely effective approach. And now I can say that we have no complications sometimes because we are also cutting the machine for the duration of the pressure in the cerebrospinal fluid. So sometimes after the incision of the optic machine, we observe not diamond, but all beginning the activity of the different words. But sometimes it's for good, sometimes it's
Do you collaborate with ophthalmologists?
The only collaboration is because they prepare patients and they come to patients sometimes when they refer patients to us. From the beginning, when we started, because it's not normal that ENT surgery or neurosurgery is happening in Italy. Because this is a field which is not familiar with. So there was a problem at the beginning. So there was a very nice professor from our department of ophthalmology, Professor, and she was third class, telling me what to do. She was just standing behind me, so we did that actually it is ideal. So it's not something naturally, because if you have a bone tumor which is infiltrating muscles, then we are taking a safe suture, so we are cutting conjunctiva, we are taking a safe suture on the muscle, and we are pulling the muscle, and then you can recognize where is the muscle, even if all this area is infiltrated, and then you can avoid cutting on the muscle. It's also helpful. We use wooden sticks with the cover.
Any questions? No, please. Thank you very much. Now I'm calling Professor Godsi for juvenile lymphoma. Sounds interesting. Yeah.
You have apples? Okay. Okay. Good afternoon, ladies and gentlemen. It's great pleasure. It's a great pleasure and honor me to stay here with all of you. And I was since going to some years about the 5 years
probably change the way of thinking about celebrate tumor. Zanim się komputery dogadają, a few words about Poznań, about myself, about my connection to Warsaw. Proszę Państwa, moje związki z Włochem nie wiem, że kilka słów na temat mojej osoby. Nie wiem, będzie w Warszawie, może wspomnę tylko po polsku chwilę, że dla Państwa kiedyś były takie czasy, gdzie egzamin specjalizacyjny z narodowym stało się egzaminem historii. I pan profesor Kuchwa do mnie zaprosił, pan profesor Jaczewski kazał się niego wycofać. A jak już przyszło co do czego, to we trójkę z Państwa koleżanką, Agnieszką Ostrzelasz, uczyliśmy się razem z Marcinem tylko na temat tego miasta, w Warszawie. W Poznaniu było dzisiaj pytanie, dzisiaj odpowiedź bardzo krótko. Agnieszka mi mówi, naucz się zagajek. No to ja przez 10 minut uczyłem się zagajek różnych i kiedy pan profesor Jaczewski zadał mi pytanie włókno jak młodzieńczy, to zacząłem od Karola Marcinkowskiego, mówiąc o tym, że w połowie XVIII wieku usuwał włókniaka młodzieńczego poprzez wyrywanie z zielonymi kleszczami i następowe przypalanie gorącym żelazem. Siedział obok pan profesor Gołąbek, pan profesor Pośpiech, pan profesor Jaczewski zsunął się delikatnie po prostu mówi, a znasz pan jakieś bardziej współczesne metody wyrażenia? We know that juvenile angiofibroma is connected with threat of specific symptoms, with unilateral epistaxis, with unilateral, usually unilateral nasal obstruction, and pink mass inside the nasal cavity. It's partial disease connected with males, usually, or obviously, exclusively with males. Historically, it's benign, it's not vascularized. Specific for this disease is local invasion and spontaneous tendency for spontaneous redress after adolescence. In specific situation, in huge advanced situation, we may observe the penetration of the tumor into the medium, and in some situation, when, like on this case, that's partially damaged, we may observe the penetration of the posterior cranial fossa. The selection of disease is unknown because quite rarely observe initial symptoms of the juvenile angiofibroma, but if you are lucky, you may observe the informal CT scans or MRI first initial situation. This one picture was done, this one CT was done because of the head trauma in this boy with the tumor from this picture. 18 months prior to the first symptoms connected with total nasal obstruction. What's very important, the initial diagnosis is usually done using endoscopy. We may perform anterior endoscopy, posterior endoscopy, and in such situation the view is not specific. It's very important to check if the tumor is bleeding during the procedure. If no, it's impossible to do the biopsy, but not always. In some situation, in some specific condition, we may perform the biopsy to confirm the histological diagnosis of the type of the tumor. It is necessary to do some specific suture on the end of the part of the tumor, calculate and check and send the pathologist in some situation for the intraoperative diagnosis. This is quite dangerous, but in specific situation it's possible to do. We know that we have lots of types of staging system for juvenile angiofibroma, but the last revision a couple of years ago qualified the juvenile angiofibroma into 3 different groups. Before the operation, in our center, we try to perform all the time vascular analysis of the tumor. The angiography was done to precise the localization of the main supply vessels. And up to
2014, we performed the embolization in all cases. Last 5 years, we avoid to embolize our cases of juvenile myelofibromas, and I will show you the results and the current effects of our surgery. The problems with the embolization is connected with risk of adverse phenomena, and we have different options of the embolization. We use PDN, we use onyx glue. Onyx glue is most effective, but in some situations may cause the problems during the cauterization of the tumor and during the removing of the tumor using a microdebrider. We may perform direct intralesional embolization, but we should consider that there is a connection between the external and internal carotid artery at different levels. And the main importance is in the lateral trunk. There is the specific small vessels, small arteries inside the cavernous sinus, connected the cavernous sinus and the intracranial part of the internal carotid artery. What we observed is that after the embolization, in 12 hours, the size of the intralateral trunk may double, and in 2 days, the flow through the intralateral trunk is 4 to 6 times higher, bigger than before the embolization. This is the view pre-embolization. The result of the embolization, the result is fantastic. But 24 hours, the view of the tumor and the level of the vascularization is the same. I want to show you the case of the tumor with type 3 invasive tumor with damage of the anterior and lateral skull base. How to prepare yourself for the bleeding? It's possible to put, like Professor said us before, some specific sutures, or not sutures, the bindings on the external carotid artery. The surgical approach we used till 2014 was a fascial globing approach. Now we use exclusively intranasal endoscopy approach. The risk factors for the treatment failure are connected with clinical development, with the tumor size, with the tumor volume, more than 65 millimeters, with non-radical excision. The failure are connected also with the very young age of the patient and with the embolization. What's the reason for? We don't know exactly. Probably we feel more comfortable and we are less secure when we embolize the patient. The last stage of this picture was missing. The last staging showed us that there is a strong relation between the localization of the tumor, between the advancement of the tumor and the blood loss, and the time of the operation and the risk of recurrences. To control the bleeding from the intracranial part of the tumor, when we observe the intracranial invasion, we usually cooperate with our neurosurgeons. It allows us for safe procedure and for the reduction of the blood loss during the surgery. When we observe the optic nerve involvement, we always ask our ophthalmologist about the analysis and about the analysis of the evoked potentials from the optic nerve. We observe the changes when the tumor may cover or may surround the optic nerve. Sometimes happens. That it's very important to ask the neurosurgeons to remove the part of the tumor covering the optic nerve and anterior communicating artery also. There's the situation very operatively done before the endoscopic surgery. We usually try to avoid the pinhole surgery. We perform quite wide section of the posterior part of the nasal septum. Sometimes we create the small hole inside the septum to use organs technique and to have a space for good instrumentation, for lots of numbers of instruments, different types of endoscope. Usually we perform the large enterostomy with the routing of the lacrimal duct. We try to we open the posterior maxillary fossa, try to identify the sphenopalpar artery, but we go as far as possible to the sideways to find the main trunk of the maxillary artery. It's usually covered by fat tissue. Using ostium seeker, we elevate the maxillary artery and clip it or coagulate it twice or 3 times at different levels to reduce the blood loss during the surgery. It is very important to use the specific technique of preparation of the tumor, gently pull and release the tumor, pull and release, because it almost always allows us for the specific removal of the tumor without the risk of the remnants of the tumor inside the ptergopalpal fossa or submaxillary fossa. We always try to identify all supplying artery of the tumor and try to pick every one place where is risk for the blood. It's made our operation more safe. It's made our procedure longer than usual, but reduces significantly the blood loss during this procedure. Vessel by vessel, artery by artery is closed by the different techniques. This part of this patient was not embolized before the surgery. You may observe here the view to the pterygo palpal canal. Okay. And there is the view 7 days post-op. And the technique of pull and release of the tumor with removal of the tumor from the subtemporal fossa. On the left side, we see the fat tissue inside the subtemporal fossa. The status view. We usually check the area using the angle endoscope, 30 degree 45 up to 70 degree. And this is the same situation on the right side. It's different. Another patient. On the right side, there is a removal of the part of the tumor from the subtemporal fossa. And in a few seconds, you may see the fat tissue on the right side in the subtemporal fossa. There is the damage of the clitus and the view to the posterior panel, fossa, to the cell. The risk factor for recurrence is connected with multi-compartmental localization of the tumor, with skull-based involvement, with intracranial extension, with supplying artery from the supplying vessel from the internal carotid artery, with young age of the patient, less than 8 years of age, and with positive margins. The piecemeal technique should be avoided, but to be honest, I've never removed the tumor, this type, this size of the tumor, in one part, in one place. It's very important to differentiate and to recognize if you have the problems with recurrence or with persistent residual tumor. The persistent, the residual disease may be left intentionally, but we try to avoid this as possible. How to detect persistent juvenile fibroma? It's very important to perform early post-operative CT scanning with or MRI and a long-term follow-up. The radiological criteria for the persistent disease are connected with high contrast tissue in the operated area, nodular shape into or more planes, and lesion site involved by juvenile angiofibroma perioperatively. Is the child with time-free tumor post-operatively? This endoscopy was at 6 months post-op. And what's very important, in our medical center, we try to use the north-hand technique to check one after another, this step by step of the procedure. We try to avoid the fragmentation that our hands doesn't work. We try to get broad access to the posterior part of the to the lateral part of the temporal and subtemporal fossa, and we try to trim all the bony part damaged by the tumor initially. If most of those factors are respected, we perform full rhinoscopy after the removal of the nasal packing, and every 3 weeks post-operatively up to 3 months. We perform MRI 3 months and 2 years after the removal of the tumor. If no, the MRI was done after the removal of the nasal packing, and every 6 months up to 2 years post-op. And there's the patient before, the same patient after the surgery. And there's the last classification of the staging of the tumor. And I want to present some data from our medical center from the years 2010-2014, when we used mid-facial developing approach plus endoscope. What's very important, we reduce the blood loss up to 30% of the initial data. But the time of the surgery, especially in more advanced tumors, was almost doubled. When the procedure in small child or in child we suspect to have for more than 10 hours, we usually try to break the procedure. We send the child for the ICU for 1 or 2 days and take the child for the second part of the surgery, because it is very important to get the balance in the behavior of the patient. Thank you.
Thank you for this extraordinary presentation. But I have one remark. Some people say, it's juvenile angiofibroma, will go out by itself. But it's not true. Some of them are really like a nasty malignant tumors. I remember one case that was 90% irrigated from the carotid artery and has all feeding arteries connected to the parenchymal. So how can you quantify it? You have to go frontally. And in that case, I advise you to use a one case. I started with juveniles with that instrument, and it's perfect for that purpose. Yeah. And can we address a comment and any questions for this beautiful lecture? No? Okay. Thank you. Thank you very much. Now I'm calling Professor Gottlieb. Suppose from this clinic to give us a lecture about transnasal endoscopic approaches to the lateral recess of the spinal sinus.
unpleasant face. Okay, thank you very much for the invitation. I took my exam a few years later in Poznań, and then I had to got to know very familiar with Poznań School of Photography. It was not an easy task. But my topic is 4.5 to 1 anatomical equation. Basically, these are the thousands. In this area, we have from witnesses, where this is because the tracing is it's not good. So first, let's take a tour through some summary of anatomy. So as we are going from front to back, the posterior wall of the maxillary sinus, we end up in the tracheoplatine fossa, which is here, and then we can see seven connections of the tracheoplatine fossa, which we should be familiar with. And we know that vascular structures are covering neural structures located behind. And if we look at the cadaver specimen, this is the tracheal plate, lateral tracheal plate, and here we can see medial nerve, pharyngeal nerve entering the paratovaginal canal, and maxillary nerve. And here, if we are digging far enough, we will see mandibular nerve. So what the place that we are interested in is here. And on coronal CT scan, we can see between medial and maxillary nerve. What common pathologies can we find there? So inflammatory changes, many times during the operations performed for chronic rhinosinusitis, we can see some mucosal changes or some mucus there. Sometimes mesotoma can be there, also some benign tumors like most commonly referred papilloma, and cephalocells, meningeal cells and meningeal cells. So my goal is to present a quick overview of the strategies, surgical strategies, how to get there and how to cope with this type of pathology. So what we can do, how we can get there is get there through the sphenoid sinus directly and then look around the corner, but it's not a good idea because then you have very limited possibility to maneuver with the tools. So the solution for this is transperineal approach, and in some cases we can do something else, which is to go directly to the lateral recess, and I will show it in some clinical cases. So just before we all know what was meningeal cephalocele is its carriation of the intracranial content, and in case of lateral recess of the sphenoid sinus, formerly it was known as Sternberg canal cephaloceles, and now we know that it's not true because Sternberg described it medially to the foramen rotundum. And most of these pathologies, they are located laterally, so it's not true Sternberg canal cephalocele. So first, I would like to present a case which shows how we should not do this anymore. So this is the approach through the sphenoid sinus, and this was 70 years old female with the right side CSF leak with episodes of meningitis. And this was like more than 10 years ago. We didn't have that much experience in this type of surgery. So what we did here is the lesion. You can see the defect of the skull base. And this is the MRI. T2 images showing this encephalocele. And what we did was we simply get this is the posterior wall of the maxillary sinus, this is the encephalocele pulsating, and what we did, we just performed two iteration. So first we calculated, diminished the lesion size, and put some fat, some fascia, some glue, another layer of fat, and the patient is fine. However, we know that this is not the method of choice because we may face mucus, recurrent CSF leaks, and this is not the way how it should be handled because it should be removed. This encephalocele should be removed at the site of defect should be closed. So to do it, we may perform transfemoral approach, and to do it, we first open pectoral fossa. It's a question how much of the structure we should remove. It should be partial maxillectomy, or perhaps we don't need any extended approaches, and we can use what I will show later is that we can only perform white and needle arthrostomy, or inferior arthrostomy in some cases. So then we are lateralizing the content of the pectoral fossa, and by doing so we are getting straight way to the vision. So what we do is white needle arthrostomy, sphenopalatine artery coagulation, sternotomy, removal of posterior wall of the maxillary sinus, and the pectoralatine fossa content is neutralized. We remove and then use and reconstruct the skull. So this is the case, 60 years old patient with left side of CSF leak. He had one episode of meningitis in past. MRI, T2 images, and this is the surgery. So we start with just treating the middle tablet and arsonectomy. This is coagulation of sphenopalatine artery. And then we are opening posterior ethmoids. We can see the mucosa, which is swollen because of the presence of CSF leak, and we are removing the posterior wall of the maxillary sinus, exposing content of the pectoralatine fossa, and then we can see the encephalocele. Still, it's not reduced to the size that is required for proper reconstruction. And then we also used, in this case, we used some septal cartilage here. So then it was covered with artificial dura, and then some surgery cells, some glue, and that was it. So this is the view, endoscopic view, post-operatively. The middle cabinet, single sinus, carotid artery, this is the entrance to the lateral recess of the sphenoid. And we can nicely see well healed So if we want to, sometimes we need to go more laterally. This is, in this case, 70 years old obese male with no CSF leak. He's on anticoagulants, and this was random finding in the city. He was sent from a hospital, and hospital biopsy was taken, and there was a suspicion of inverted papilloma. Clearly, if you look closer, you can see the bony damage here. So the question is it really inverted papilloma? Perhaps there is some malignant transformation of histopathology is totally different. So, and you can see that the internal carotid artery is exposed. So the question is how to deal with this type of pathology. So we did it together with my colleague neurosurgeon, and I asked him, okay, let's start that least invasive type of surgery we can do. If there are any problems, then perhaps we can extend the approach. And this was my decision. So in this case, it was quite easy to go from not like the way I showed before, but transceptally, because there was already set up perforation. I actually, after the biopsy performed in the hospital. So this is the procedure. You can see the perforation. This is the transient process and alignment of the middle tablet. Once again, this is crystal medalis, xenoplatin artery was coagulated. This is mucoperiostrum of the posterior wall of the maxillary sinus. It's nice to have it lateralized because then we can cover the cave. And we are removing the posterior bony wall of the maxillary sinus. This is maxillary artery already coagulated. We have no clips, unfortunately, but coagulation is quite effective, as you can see. And then this trabecular content was really very compressed and very thin. So it was not a big problem to get there, to widen this approach and to go laterally. As you can see, the central compartment of the tumor of the sinus was removed. And then we can go further laterally to remove the tumor. There was no single attachment, unfortunately, and so we go on the artery, and this is our most lateral limit of, and as you can see, the visualization is quite okay, and this is internal carotid artery. We are peeling off the mucosa. This is mucosa from the internal carotid artery. And step by step, piece by piece, this is what we could do. There was still some tumor in the posterior ethmoid, so we removed it. As you can see, the approach was quite limited, and I could do it without fork technique for the most of the time, with exception for some stages of surgery, because there was some remnant of the tumor in opticocarotid recess, as you can see here. So this was quite difficult to remove, but we did it. So far I have no post-operative CT, because this was quite recent case. So then we put the mucoperiostrum on the posterior wall of the maxillary sinus duct, and that's it. Okay. The question is, do we always have to open, to lateralize the content of the trabecular fossa? And perhaps we can go directly to the lateral recess of the sinus. So, of course we can, not in all of the cases, but this is the case of direct approach to trabecular fossa and temporal fossa. So this is the deep bony defect. And these are coronal scans, so here you can see the site of entrance of this endophallocele. So what I did is we went directly through the posterior wall of the maxillary sinus without coagulation of the Catholic artery, and with damaging the structures around. And, so this is what was done. This is posterior wall of the dorsal sinus. Once again, the mucoperiosity was naturalized. Then we got oriented by intraorbital nerve. This is the posterior wall, which was coagulated, and this is the most shallow part of the trabecular and intratemporal fossa. So by drilling, we got into the lateral recess. This is already an encephalocene, so we are diminishing distance with cautery, and it's removed. In one, you will see the site of entrance. This is the defect of setting. The problem is now we are dissecting the dura from the bone, and then I put some piece of bone taken from lamina perpendicularis. This one piece was not enough, so we had to stabilize it with another piece. The most problematic thing is how to bring it anteriorly. Then we covered it with free mucoperiostin, put some sponges, and that was it. And this is before surgery, and this is after surgery. So you can see that this bony fold was revealed, and you can hardly see that there was anything going on there. Okay, so to summarize, we got several ways how to get to the lateral recess of the spinal sinus. Basically, this is the most commonly used one nowadays is transperigoidal approach. And of course, there is a question how to what sort of approach to get there in terms of shall we perform partial maxillectomy, or you can do it more conservatively, minimally. This case, it was done basically through inferior antrostomy. So there was little antrostomy performed, but it was as an additional corridor, so it was pretty invasive. And in case of bigger defects, you know that we have to apply something more than just 3 grafts, and this, so we can use an after, for example. Okay, thank you very much.
Thank you very much for this beautiful lecture about approaches to this difficult area. Are there any questions? I want to congratulate you for your work. And I'm now calling Professor Nicola. Could you tell us something about Galvestino's presentation of cases?
Not to be mistaken, Professor Kubler Mohammadi was sitting here in conference, and I'm just sitting here. And nonetheless, both of us the representatives of Medical University and Unity Department of Susi Hospital, which is located in capital city of Kazakhstan. And I have to say that our department has a 10-year experience of collaboration with Professor Nemchik and his department. And it's a pleasure to present some of the results of our cooperation. So I will tell about the cases of vascular tumors of the ENT region. And to begin with, I have to say that head and neck vascular tumors are exceedingly rare. And the first case will be about glomus tumors. And glomus tumors of middle ear, one of the most common tumor after schwannoma. So, to speak about the first case. We had a patient that presented symptoms of facial palsy for about 1 year without any preceding complaints. And here you can see that he has some problems of closing his eye, blowing his cheek, facial weakness. And on physical examination, we could see that the left tympanic membrane is reddish color and bulging. On CT images, you can see that there is a bone erosion with some pathologic tissue on the left side, and on the MRI contrast enhanced MRI, you can see that there is a progressive tumor in the temporal region going to the cerebral pointing angle on the left side, and the size of the tumor was the width 5.8 and the length and the height was 6.1 centimeters. So, as the first step of our treatment, we performed embolization of main uterine vessel, and before embolization we performed angiography. As you can see here that the tumor was highly vascularized and the result of embolization. And after the 3rd days of after the embolization, the subtotal pituitary was performed by Professor Nemchik, and the surgery began with the post-oral incision, and the external auditory canal was closed. Then the salivary part of facial nerve was found and was healthy part. After that, the mastoidectomy was performed, and there was an appearance of tumor right after the cortical bone removal. Here you can see some part of origorhynectomy. So the tumor was separated from all the surrounding tissue. Here you can see that tumor was deeply attached to dura mater. So here is the separation of carotid artery from tumor masses. And the attachment of bulbar uvularis from tumor masses too was performed. After that, it was visible that there was a large part of facial nerve that was invaded by tumor masses, and therefore the damaged facial nerve tissue were removed. And so, because I tried to perform anastomosis, and due to the fact that there was a large defect of facial nerve, it was hard to perform end-to-end anastomosis, and for about the last 2 months, the patient presented some hypoglossal nerve palsy. He had deviation of tone and some slurred speech, and therefore it was hard to perform again the anastomosis between hypoglossal nerve and facial nerve. And therefore the incision was extended to the neck, and the anastomosis between ansa cervicalis and the remnants of facial nerve was performed. Here you can see some highlights just of suture. And here is the post-operative look. So the whole operation took place for about, it was lasted for 14 hours, and the histopathological results were hemodectoma, and the post-operative cavity was filled with abdominal fat. So here is the check of our patient after the 3 days after surgery. Here is, you can see that he has no vestibular disorders. years, 1 month after surgery, you can see here a fat tissue that filled the postoperative cavity. And so the next case I will quickly show that it's a patient that had appearance of vascular formation on external nose at the age of 4 months. And during her life, she had some complaints about nasal bleeding and discomfort and pain in her right orbit. And here is the CT scan. You can see that there is gigantic tumor mass that goes to orbital lobe, maxillary sinus, goes to another side of the cavity. Another correction. And you can see here that it was highly vascularized. And again, this patient was, as of the first step, was performed embolization of main uterine vessel. After that, the patient was took for operation procedure, and we used open access because it was the damage of the skin. And after the skin incision, you can see that there were extended vesicle network, and the vessels were dilated. And using the open access, tumor masses were separated from orbital wall, from maxillary sinus, from lunar. Here you can see all the tumor that were removed and sutured. And this is a patient after 1 year. You can see that there is no sort of visible scar on her face. And just to quickly sum up, I just wanted to say that we have about from 4 to 6 or 7 some vascular tumors of the intrusion, and as a first step we use embolization before entering and the embolization of the vessels, to which we use surgery. And here is the team that will for about 14 hours of operation. And this is a short glance at our city. So here, that's all. Thank you for your attention.
Thank you very much for the presentation of these very interesting cases. And with this, I will conclude the panelists, and I will have the microphone to mention. I would like to use this opportunity to thank you again and express my gratitude to be here. And I really enjoyed this day. All panelists, I would say, I learned a lot from this here. Professional way and more human way, and thank you very much.
Thank you. So I'm very glad that we could prepare this course and conference, because it is not easy, and we try to do our best to show to young people overview of the whole skull-based surgery. So I think that really we fulfill your expectances, and you are glad, and you knew what is now in this field. And I really also can say with that it is great success, because your young group in ESBS, which is this, I think, very interesting idea to improve interest in this field for young person. So I am really glad that this young group set up organizations. So they create this group, and they make the board. The president of the board is the chairman. President, how it is? Chairman is Klaudina Fuzynska. She made all this organization regulation here. They Klaudina. Secretary will be Jan Lazak from Prague.
unfortunately he should go back home. And Secretary Octavio Augusto Lavaron, Octavio, and all colleagues, Jan Tomasz Wojciechowski, Maja Malic, Mirosław Malic, Matija Mamic, Łukasz Przepiórka, that's the collegial advisory board, I can say. So congratulations, and we as ESBS very welcome you to close cooperation, because you are in, but you will be really close to the our I can say activity for different purposes. So you are welcoming to close cooperation with executive committee. So thank you very much for this good question, because of course good done is half done, but I think that we will continue. So once more, I would like to thank our lecturer who gave us excellent lecture, and we know that sometimes changes, and I think that everybody from us, even experienced, could find very interesting thing to adopt and practice, a very interesting opinion shared with us. So I think that this is very fruitful Congress in terms of scientific level as well. So I would like in the end thanks all participants to be as resistant for this difficult time before Christmas being here. And at the end, I would like to thank all team from the department and from Ausmet and from Ukraine who are really involved in organization, especially Maria Małkowska, president of Ausmet, Vladimir Lavinis, chief of Polkrain, and our colleagues since very shortly, because he was, I can say, the spiritus movie of this all technical support which is here, and I can say that thank you for your work. And I, of course, should talk about this new technical devices which can be used in our everyday practice, or maybe in the future. As you see, you observe that it is not so easy, because even so, some trick like connection in another computer can change everything in the system. But I can say that we can try work on it to improve our experience in this, expertise in this, and because you maybe not everybody knows that every day of this conference the part was broadcasted. So this is even more difficult to have transmission broadcasting from different sides. So that's it is very interesting to know also that we have now this good opportunity to during the presentation have so nice tools to underline or to draw something on the screen, and this is broadcasting to another, not only here this sign we can draw, because broadcasting to everybody, even those who switch on the mobile telephone, they know what everything, every detail we
So thank you very much once more, and we now can rest and benefit from the weekend. Thank you very much. And because lunch is waiting a little maybe colder than we wanted to, but anyway, we should be hurried for it. Thank you.
Yes.